Huh.
Okay, can everybody, I need to, I apologize again for failing to keep us on track, but now bring us to convene for the afternoon session of today's meeting of the Advisory Committee on Immunization Practices, or the ACIP. The first item on the afternoon schedule is a continuation on the topic of hepatitis B vaccines, beginning with a summary of information and a summary of information from Dr. Pebsworth. I will read the proposed question language after I summarize my understanding of what we have as agreements and disagreements, and then we will proceed with the VFC presentation, CMS comments, and downstream agenda items. So with that, Dr. Pebsworth, please proceed.
Good afternoon. I'd like to describe what the Childhood and Adolescent Schedule Work Group did to prepare for today. We had a process and we had findings, and we developed some proposed voting language, which Dr. Malone will be discussing. Next slide, please. As I mentioned this morning, 4 of the members of the work group were or are still ACIP members. We had outside experts, Dr. Brian Morse and Dr. Christine Staubel-Ben, and an ex officio participated also in the work group meetings. Next slide, please. The policy request made to the work group was to assess the use of a universal birth dose of hepatitis B vaccine in children whose mothers were antigen negative. And by nature of discussing the birth dose, it's unavoidable to also then talk about subsequent doses too. So even though the request was to focus on just the birth dose, we also touched on topics that are relevant to future doses as well in this particular population of children, those whose mothers are hepatitis B surface antigen negative. And as I mentioned earlier this morning, the terms of reference document for this work group includes the following language: review the efficacy and safety of the immunization schedule for children and adolescents, identify efficacy and safety problems, and address stakeholder concerns. I mentioned this morning some of the stakeholder concerns that have been raised in survey research, and I shared those. Next slide, please. So again, the reason this topic came to us and we're working on it is because there was information from shareholders, feedback, primarily parents. There's also the perception that there is a misalignment of the U.S. recommendation as it relates to other similarly situated countries, as shown in the bar chart that was at the tail end of my presentation this morning. And it's been a long time since the last comprehensive review of hepatitis B vaccine was done by the work groups. Next slide, please. The finding of the work groups, hold on a second. Yes, process. So we picked up what we worked on following the September meeting. So at the September meeting, there was a request made for some additional information. We took that back to the work group. We prepared a request to CDC for additional information and data. We gave CDC 16 questions that they worked on and provided answers back to us in our work group meetings. Between October the 17th and November 24th, the work group met 7 times. We had 12 presentations by CDC staff, work group members, and invited ad hoc experts, and they covered the topics of clinical ethics, non-specific vaccination effects, aluminum adjuvant exposures, clinical practice challenges and solutions, and the Alaska hepatitis B vaccine trials. Next slide, please. Through a series of polls that were disseminated amongst the work group members, there are some themes and findings. Areas of full or nearly full agreement include the following items: that hepatitis B virus can be transmitted vertically and horizontally to infants, is a serious disease, and can be prevented by vaccination and the hepatitis B vaccine, and also immune globulin in certain populations. There is uncertainty about the true rates of incidence, prevalence, and horizontal transmission rates in the U.S. population, as Dr. Neveson described. The third point is that there is uncertainty about whether all 3 doses are needed to produce and acquire protection. Fourth point is there are gaps in evidence and limitations, as Mark described, and the evidence of safety per the grade system of evaluating the quality of scientific evidence found that the safety evidence available to us was characterized as poor. Next slide, please. Infants born to mothers who test positive for hepatitis B surface antigen should continue to be vaccinated with hepatitis B vaccine and receive hepatitis B immunoglobulin soon after birth. There was full or nearly full agreement that any gaps in screening pregnant women for the hepatitis B surface antigen should be eliminated so that all infants receive appropriate care. Rescreening of pregnant mothers upon admission for delivery should be considered so that there are no mothers whose hepatitis B surface antigen status is unknown. We regard that as a quality of care problem. and a serious one at that, if not a medical error, and something that should be characterized as a never event. It has implications for the care that the baby receives and follow-up in the community. Lastly, infants born to mothers who test negative for hepatitis B surface antigen have extremely low risk of horizontal infection during childhood and particularly in the first month of life, and therefore do not need to be routinely vaccinated with the hepatitis B vaccine at birth. Next slide, please. There were some central themes related to the type of preventive care needed for hepatitis B situations. The first being that there is a need to improve the quality and appropriateness of hepatitis B preventive care. Again, screen all pregnant mothers. There should be no unknowns, and appropriately treat all newborns based on the mother's actual status. The second item is to minimize adverse events in vulnerable infants, avoid unnecessary life exposures. The third item is fostering individual-based decision-making and respect for parental autonomy, permit clinical flexibility and individual risk assessments. The fourth item is to improve safety monitoring and research. The gaps between what we think we know about safety and what we truly know about safety need to be closed. Fifth item is that the U.S. policy may need to be modified, considered in light of the situation that is in other countries. We discussed return to a targeted and successful strategy, more in line with other developed countries with low endemicity. Next slide, please. The work group evaluated 3 different voting options in large categories. There was an option to consider continuing universal vaccination of all infants, and there was 2 of the work group members preferred that option. There was also an option for no recommendation whatsoever for this group of babies. One work group member preferred that. The remainder of the work group members, which was the majority, preferred an individual-based decision-making option. But I want to point out that the second choice for half of the work group was the no recommendation option. The primary reason that that was not preferred was because of concern about acceptability. Next slide, please. The rationale for preferring an individual-based decision-making option is that the overwhelming majority of infants born to mothers who test negative for hepatitis B surface antigen are not at risk of being infected with the hepatitis B virus, especially in the first few months of life, or the threats of infection are very low. Vaccine safety risks are not well understood and were never assessed properly. An individual risk-based approach is needed, with recommendations tailored to risk-benefit profiles and preferences involving informed consent. Next slide, please. Additional reasons for preferring an individual-based option is that the potential to allow the parent to choose a point in time closer to the onset of risky behaviors, sometimes encountered in adolescence, and for those who prefer to wait, use the catch-up schedule options as are noted in the CDC schedule beginning at age 11. It also provides options for avoiding early infancy vaccination risk associated with early infancy and adolescence when there are biological windows of vulnerability. It also creates an opportunity to use serology testing to determine whether additional doses of vaccine are needed for protection. Next slide, please. It creates an opportunity to use serology testing, that was repeated. Provides for return of decision-making to parents in concert with the healthcare provider, who wants flexible schedules and the ability to tailor care to individual patient needs. Also discussed was a 2-month age of starting the series, the additional 2 months of maturation as it relates to the blood-brain barrier, liver, and kidney function is desirable. It is in line with the policy of other comparable countries, would then permit the use of combination vaccines and limit the number of injections, as well as make lower aluminum-containing products more available. Next slide, please. There were a number of reasons why that an individual-based option was not preferred. There were concerns about rare exposures to the hepatitis B virus that could cause an infection and a chronic infection with hepatitis B virus. Concerns about acceptability to the medical and public health communities. The system that's in place will be difficult to change. It will take too much time to counsel parents about the risks and benefits, and access to educational materials isn't obvious. Concerns about liability, payments, and additional paperwork were raised. The safety concern may be more theoretical than real risk. Next slide, please. Implementation considerations involve the ability to successfully use PEP in births and hepatitis B antigen-positive mothers, the need to strengthen maternal screening programs, immigrant medical examination screening. Delaying the time of the first dose will allow choice of using different vaccines, both monovalent and polyvalent options. Next slide, please. Implementation considerations. Even under the existing universal dose policy, not all babies are vaccinated at birth, and there are no detectable increase in the incidence of hepatitis B infections. There's data from the 2016 to 2021 CMS of newborn infants. Next slide. Pregnancies and live births were coded and evaluated. Next slide. Total births, infants receiving the first hepatitis B dose by 2 years of age was 90%. Infants receiving hepatitis B birth dose was 70%. So there is some delay in uptake of hepatitis B vaccine in this population. Next slide. The age at first dose of hepatitis B vaccine, 100% of these patients had received a vaccine by the time that they were 2 years of age. And you can see a distribution of vaccine uptake according to different intervals and segments. But at present, 76% were getting a birth dose, and many were not getting a birth dose. And again, like I said, there's no observable uptake in incidence of hepatitis B infections. Next slide, please. And lastly, this is the same slide as before. The work group felt that it was very important for us to consider a variety of ethical challenges and components, and that involves potential harms and burdens on both sides of the equation, both from the disease and the vaccine. We thought it was also important to understand the impact of various policies on the autonomy of parents, the impact on equity, and expected efficiency. I explained the other ones earlier. So at this point, I'd like to turn the discussion over to Dr. Malone to talk about the voting language.
Thank you, Vicki. I think you've really nicely covered these 3 key points. I think if I understood your presentation, there's broad agreement that hepatitis B is a serious health threat with serious outcomes. That's not up for debate. Babies that with moms that are Hep B positive, antigen positive, should be vaccinated and treated with immunoglobulin. I think that's not up for debate. That's not a discussion point. There's broad consensus on that. Number three, that there's broad consensus on the need to improve screening in general and specifically in pregnancy, ideally to retest upon admission. I think that's also not up for debate, and I hear informally from our friends and colleagues at the CDC that there are active programs in progress to augment those capabilities and strengthen those capabilities within the United States healthcare system. So I think we can park those topics. Everyone, there's broad agreement on those topics. There does seem to be some disagreement that the evidence that birth dose interval and population benefits are compelling. What is the risk of horizontal infection? That seems to be a topic of some considerable discussion, and there's a diversity of opinion in that. There's also a diversity of opinion regarding the population level benefits of the existing safety net and its adequacy and penetration. I think that's another thing that is an open discussion. And I think that what I've heard, if I can summarize, hopefully this is accurate from this morning's discussion and your presentation, is that there is discussion, there is a diversity of opinion regarding the existence of evidence of harm and the confidence level that we have around that incidence of harm evidence or lack thereof. So those are topics that seem to be at the center of a lot of the discussion and are largely unresolved. I think we to be honest, we all acknowledge that there's diversity of opinion there and that there is a need for considerable additional data before we can have clear decisions. But as my friends that routinely practice medicine, I'm only licensed to practice medicine, I'm a researcher, but those that do tell me that we often in medical practice have to make decisions based on imperfect data. And we are now in a position regarding hepatitis B where we have less than perfect data. Is that fair? Okay, so with those things in mind, the work group and the broader ACIP have, with input, for instance, from CMS and those that are making decisions regarding compensation practices within CMS, which is a key determinant here of accessibility and equity. These are key criteria under the grade system. It's absolutely essential that whatever recommendations that are offered to the director. Remember, this ACIP does not set vaccine policy. Sorry, I apologize to various senators who seem to think otherwise, but in fact, the ACIP only advises the director of the CDC or the acting director about their independent review of policy issues, and it is up to the director or designated director to set policy. ACIP does not set policy. I want to be clear on that. The votes, the language of the votes that is currently under discussion includes 3 different votes, and I'm going to read that language right now for all of us. I don't think we have a slide for that. Is that true? We do not have a slide for this current language. I'm hoping that we do. Okay, so failing to see that slide, I'm going to read it. For vote number 1, this is the draft language. It's absolutely not approved. It's up for discussion. ACIP recommends a birth dose of hepatitis B virus vaccine and hepatitis B immunoglobulin for infants born to women who test HB surface antigen positive. ACIP recommends individual-based decision-making in consultation with a healthcare provider for parents deciding whether to give the hepatitis B vaccine birth dose to infants born to women who are hepatitis B surface antigen negative. Okay? So for those that are women who are documented as antigen negative, the language would recommend individual-based decision-making in consultation with healthcare promoter for parents. Parents should consult with healthcare providers and decide when or if their child will begin the hepatitis B vaccine series. And we have a footnote associated with that. Parents and healthcare providers should consider vaccine benefits, vaccine risks, and infection risks. For those not receiving the hepatitis B vaccine birth dose, it is suggested that the initial dose is administered no earlier than 2 months of age, Now I'm going to read the footnote, if I can find it here, that was added. The footnote for vote number 1 that I mentioned earlier reads, parents and healthcare providers should also consider whether there are risks, for example, such as a household member who is hepatitis B surface antigen positive, or when there is frequent contact with persons who have immigrated from areas where hepatitis B is common. So that explicitly acknowledges the high-risk population in which there is a social context which increases risk for horizontal transmission. For vote number 2, up for consideration, ACIP reaffirms the current standard of care that a birth dose of hepatitis B vaccine and hepatitis B immunoglobulin is administered for infants born to women whose hepatitis B surface antigen status is unknown. So those that do not have a known positive or negative test for hepatitis B surface antigen, we have this vote number 2 language that ACIP reaffirms current standard of care that a birth dose of hepatitis B vaccine and hepatitis B immunoglobulin is administered to infants that from mothers whose antigen status is unknown. For vote number 3, when evaluating the need for subsequent HBV vaccine dose in children, parents should consult with healthcare providers to determine if a post-vaccination anti-HB surface antigen serology testing should be offered prior to subsequent hepatitis B vaccine dose administration. Serology results should determine whether the established protective anti-hepatitis B surface titer threshold of greater than or equal to 10 milli-IU per mil has been achieved. This is the well-established threshold titer levels that is widely accepted in clinical practice. The cost of this testing should be covered by insurance. So that's the language for the 3 votes that are currently up for consideration. And with that, I transition to the Vaccines for Children presentation from Dr. Santoli of CDC. Dr. Santoli.
Hello. Yes, sir.
Yeah, I can hear you.
Okay. I've just sent an updated slide deck to make sure that what I'm going to present aligns with what you have just shared. So it may take just a second, and I apologize for that. But yeah.
Thank you for your agility and willingness to adapt to the situation.
Sure.
So a moment of quiet while Dr. Santoli's slides get loaded.
Robert, this is Cody Meissner. Are those the only three options that we can vote on?
So, Cody, I'll give you a read ahead. As you know, based on the rules of order here, ASIP members have the right to make a motion for change or alterations in the scheduling regarding whether or not we're even going to hold a vote. So as happened in the last session. So that is the language that is currently in front of us. And that language is subject to amendment by ASIP members using the proper rules of order. Have I answered your question?
No, I wanted.
Okay, so I will wait. Thank you. Thank you. That's very helpful.
Yep. So absolutely, it's open to amendments and recommendations following proper rules of order when we get to that part of the agenda, if you're okay with that.
That's perfect. Yeah. So that'll be after Dr. Santoli's presentation.
And after CMS comments from Mr. Johnson, schedule. And then if we do choose to proceed to a vote, there will be, after Johnson, there will be discussion. First, ASIP members and ex officios, and I have a list of those that wished to comment in the prior discussion section. And so I will be working down that list in this upcoming discussion, and then discussion once again from our respected liaison members. And then we get to whether or not we have perspectives from people with lived experiences. And then we have a potential motion as to whether to proceed to a vote, because public comments must immediately precede any vote that we take by ASIP charter. Roger?
I hope the coffee pot is full.
You're missing out on the chocolate-covered coffee beans that were circulated earlier. Dr. Santoli, are we good to go live?
I am checking.
Okay.
In the meantime, I'd like to note that this is the third version of the questions that we have most of the ACPI received in 72 hours. And we're trying to evaluate a moving target, and we don't even have a slide explicitly describing what questions we're supposed to answer. We only have a verbal report from the chair. So I rather protest the description that the ACIP members have been consulted in developing these questions, and hope that we can have a more timely presentation to figure out what we're voting on, rather than, what is it now, 2-3 hours before the vote? I request that we have more information, more time to evaluate these important questions.
So thank you for that. I acknowledge your point as having merit, and the appropriate time I suggest for making a motion to that effect will be after we have the perspectives from people with lived experiences, if you will tolerate that. Thank you. Are we live yet, Dr. Santoli?
I don't know.
Okay.
Dr. Malone, I'd like to ask you a question to make sure I'm asking people to pull up the right slide deck. So may this is not the slide deck. So first, would you be willing to repeat the 3 statements that you made? Because I want to make sure, I had a couple of presentations to try to be flexible. I don't want to pull the wrong one up and confuse people. So I'm wondering if you'd be willing to repeat.
Okay, so this is, forgive the audience and the public. What we're dealing with is a little audio-visual challenge, and we're just ensuring that we have harmonization in the slide deck. So the slide deck that we all hope that you have
Okay.
would indicate 3 votes. That would be the first thing that you can cross-check. And one of the items, the language for vote 2, to ensure that we're aligned,
Is it just going to show up? Sorry, I've got
to ensure that we're aligned with your presentation, language for vote 2 would say ACIP reaffirms the current standard of care is the first few sentences. You got that one?
Yeah, yes, I did it a little bit differently, as you'll see, because it fits into the resolution. But what you just said about vote 2 is reaffirming the recommendations for status unknown. And that was actually my primary question for you, sir.
Is that breathe? You want me to call a break?
We really need to know what we're voting on.
I concur. Suggested is that, do I have a motion that we take a brief respite to ensure harmonization with the slide deck that the next presenter will be providing? Do I have a motion from the floor? So moved. Do we have a second? Any opposed to taking a brief break right now for audiovisual harmonization? Okay, so moved, approved, and we'll reconvene hopefully within 5 minutes.
Thank you.
Afternoon session to order, and note that there will be a modification to the order of go for today for this session. We are going to have Andrew Johnson speak before Dr. Santoli. Then we're going to proceed through the discussion section and through the perspectives from people with lived experiences. And only after there is consensus on the we've cleared any motions to amend the language, only after we have cleared that will we have the presentation from Dr. Santoli. So with that, the next item on our agenda today, having reconvened, is to hear from CMS and its representative, Dr. Andrew Johnson.
Thank you, Dr. Malone. So I'll provide comment from a CMS perspective on the coverage implications with regard to the hepatitis B vaccine as we've discussed today. So having reviewed the new language as covered by Dr. Malone a short time ago, we have reviewed the language and it's the CMS position that regardless of testing status and with the inclusion of the individual-based decision-making language for mothers who fall in the negative category, that there are no coverage implications, and that for both positive, negative, and unknown, that there would be access to the vaccine for coverage without cost sharing at any time that the parent would prefer to get that. So regardless of the timeline for their preference.
So if I can summarize that, I think what I heard was this language will have no impact on availability of covered vaccines for parents and children. Is that true? Did I get that correctly?
Yes, sir, that's correct. That as long as made in consultation with their provider.
Thank you, sir. So with that, I open the discussion first so we're back in discussion section time now until approximately, 1:50. So we have quite a bit of time now for discussion. And we begin with ACIP members and ex officios. And at this point, I want to acknowledge and call first on Dr. Blackburn, who unfortunately I had to cut off previously, but she now has the floor.
Okay, thanks. A couple of questions, and I'll just ask them all. Do we have a risk rate for a low-risk baby? I did see in the presentation materials perinatal transmission was 0.5%, but was that overall? Do we have a rate for low-risk babies? Do we have a rate for false negative screenings? And then do we have any insight into the safety profile difference between administering at birth versus later or a delayed dose, or any difference in rate of adverse events by age of dose? I know a lot of the studies that we've seen are all shorter term, 3 days for the Linder and Andre study, 29 days for Erickson, and we do have some other safety means to gather that information, VAERS, et cetera. I did note that most of the symptoms the symptoms have to be reported by parents. And do the parents know what to look for? And are we talking to parents about what that might look like?
Okay, so I'm confused. Can you walk me through, what was question number 1 and who should we direct that to?
Maybe this would be for Dr. Nevson or Pebsworth. Do we have a rate of risk for a low-risk baby?
What is the risk?
If I understood correctly, I think that you ask, are there risk factors for a woman to test positive or to have infection while she is pregnant, right? Is that kind of the underlying question?
No. More, I guess my question is more if the mother is negative and there is a decision to delay, what would that risk be for a low-risk baby?
So is that, are you asking about horizontal transmission? Like so that's, we know that from the testimony from Dr. Pebsworth's committee, working group, we know that risk of horizontal transmission is social context dependent. Is that true, Dr. Pebsworth?
Yes.
Mic on. So it's variable. Do we have any numbers, Dr. Pebsworth, around the horizontal transmission risk? And if you're not aware of them, I next need to call on the CDC subject matter experts. Over.
No, I believe that those data were not available. It's a very rare occurrence in the U.S. You're talking about the hepatitis B negative mothers, children's. There is increased risk in certain situations, certain ethnic groups, and I think there are, risk with household contacts of sorts that not necessarily the mother. But that was finding data and case studies to support the concern was difficult.
So let's toss that question to our subject matter expert panel at the CDC. What data can you cite for us regarding horizontal transmission risk in the United States in the current time frame?
This is Dr. Langer from the Hepatitis Center. Thank you very much for the question. I think the challenge you run into is how are you defining a low-risk baby? And that probably gets into a little bit of what Dr. Pebsworth was mentioning about social context. But I don't know that there is any way at the time that the child is born to categorize them as low risk or medium risk or high risk, other than knowing if you know the mother's test result. To the best of my knowledge, we don't have any recent data with regard to exactly how frequently horizontal transmission happens, but we do certainly have historical data that demonstrates that horizontal transmission has happened in the United States. And one thing I just want to sort of encourage everybody to be cautious about is, if you look at contemporary data, you're looking at data in the context of a high amount of birth dose vaccination coverage. So looking at recent data and saying, well, there's not very much horizontal transmission doesn't mean that it can't happen. It means that the vaccine is preventing it. So you have to look at data from prior to 1991 to see how common it was at the time before we introduced the universal birth dose vaccine. And we do have publications and individual studies and analyses that have looked at that, but we don't necessarily have like a population level surveillance result to answer that question.
So, Roger that. My understanding from practicing pediatricians is that it's expected that the history taken by the primary care physician would identify the higher risk social context. I see Dr. Griffin concurring with that. So with that discussion,
can I respond to? Yeah. So I think that we tend to sometimes confuse when we talk about this risk between our beliefs and our assumptions and what data do we really have. And I think that even today, as we mentioned already, there are many countries in which the birth dose does not exist. Some of these countries, like Canada, has immigration from Asian countries like ourselves. I think in Europe you have immigration from other countries that could be also with the high prevalence of hepatitis B. And even when we look on earlier data from the US, there was never a rigorous quantification at the population level that this is a real phenomena that is happening beyond anecdotal stories. And I think that these are the facts. Now, you know, at this point, you can have two hypotheses to explain these facts. Either we were completely negligent and we never bothered to document these things, or that this is not a truly common scenario in most settings. And I think that it's much more plausible that the latter is the explanation. And, you know, in the absence of data, what we often do in order to actually create kind of a sense of urgency, we rely on models. And some of the models that we currently rely to justify this phenomena are models that are not even able to explain the observed data, which is maybe the most minimal thing that you want to require from a model, unless you want to stay in what you created in your imagination. So when I look on the totality of the evidence, the very anecdotal, at best, anecdotal and very, very sparse documentation of even single cases, right? Other countries that don't have the universal birth dose and don't seem to have this kind of problem more or less than what we have here in the US. But also the slides that we saw from Dr. Nevison earlier, where you basically look on the population level incidence rates, and you see where did the major decrease happen. Most of the decrease happened in the older ages, 20 and above, not among children, and it happens with populations that were not subject to the universal population dose. So I have to say that I find it very hard to convince myself that there is a true evidence that this is more of a very, very low risk, that, you know, freak accidents can happen, you know, these scenarios can happen. In some settings, maybe it's more likely to happen, slightly more likely. But I think that to make the argument that this is a real scenario is more of a speculation rather than something that is being supported by data at the moment.
Okay, so
Robert, can I make a comment to about Dr. Blackburn's question? You know, that is in terms of detecting mothers based on their history as to whether or not they might be hepatitis B surface antigen positive or a chronic carrier. It's very unlikely that people will be adequately identified. And we learned that with the HIV story. You could ask a patient if they might have HIV, and they would say no. But when they were tested, we found out that was indeed not the case.
Cody, I think you didn't understand the question. As I understood her question, it was about horizontal transmission risk when they're not from mom, but rather from the broader social context, family members. My understanding from what I have learned from the working group is that practicing pediatricians in high-risk communities, such as economically disadvantaged Asian immigrant populations that may be clustered in certain regions, is that their normal practice is to elicit a history around the issue of whether or not there is risk to newborn of horizontal transmission from other social contexts other than mom. Did I understand that correctly in your question? Yes. Okay, so Cody, has that clarified your query?
Yeah, I thought I thought the question was if a mother is inadvertently classified as hepatitis B surface antigen positive, and the child does not get identified, can the vaccine be administered later? And I was going to ask Dr. Langer, after 1 month of age, the vaccine probably has very little impact on transmission to the baby. Is that correct?
Yes, that's correct. The vaccine efficacy as post-exposure prophylaxis rapidly drops off by hours. That's why the current recommendation says for a positive for a baby that's born to a mother who's positive or a mother who's unknown, and that's actually something that we wanted to ask about, why unknown in the new vote language has been separated from positive. That baby should be vaccinated within 12 hours of birth. And for a known negative mother, then we allow for, okay, you can wait till 24 hours of birth. So literally with every hour that goes by, the likelihood that you will successfully prevent the infection decreases.
Roger.
And certainly
so
waiting
that,
to
so,
30 days would be a definite disadvantage for the baby.
But Cody, we already established that there's consensus on that. And in answer to the query, why vote 2, the answer is because there are members of the committee that were not comfortable having the topic in vote 2 incorporated within vote 1. And so it was broken out so that there's an opportunity for the membership to determine whether or not they are aligned with both clauses or just one of those two clauses. Have I answered your question, sir?
I guess so. I'm still not entirely clear what the question is going to be, Robert, but
right.
Yes.
But I gently request, in the interest of time, that we proceed to exactly that topic of the language associated with these questions, whether or not it requires amendment or is merits proceeding to vote.
Just before that, I want to make an important point, and that is that you have said that we have reached consensus, and that is incorrect. The work group reached consensus on some of these points, and the ACIP itself as a whole body has not reached consensus. That is why we're debating this,
I think that's self-evident. I think that's self-evident in the fact that we're now in discussion.
No, it is the work group that has reached consensus.
We absolutely
consensus.
have not reached consensus.
You have said we have reached consensus.
Then I either misspoke or you misheard. I apologize.
Yes, you misspoke.
Then I apologize for my limitations in communication. Regardless,
I appreciate that.
Yeah, you did say it, Robert.
Okay, then duly noted, and I accept responsibility for my misspeaking. And overgeneralization by using the term we when I was referring to, or hopefully intending to refer to the subgroup or the working group. Regardless, before you now in this slide is a language for consideration for vote. Right now, I suggest that we focus on whether or not there are motions to amend that language that's separate from whether or not there's a motion to approve it. And those motions to amend, I believe, must be restricted to ACIP members. Can you confirm? Yes, so I have that confirmation from Mina. So open for discussion right now, prerogative of the chair, is whether or not there is a motion to amend this language.
I have a question, because there's something different up there on my paper versus someone mentioned, and didn't catch whose voice it was, about mothers of unknown status. That is not it. All this language does is if you're hepatitis B positive, vaccinate. If you're hepatitis B unknown, established, then this is the language. I don't see anything about, I hope I said that right. I don't see anything about unknown status moms. Am I correct?
That language is in vote number 2.
Okay. I just wanted to.
Hence the confusion. I apologize. I'm sure this is my fault also. Up for discussion is language for vote number 1.
So I'd like to make a
Can you
motion.
read it,
Yes,
Robert?
yeah, and Dr. Pollack is asking to
I'd
speak.
like to make a motion to amend vote number 1.
Okay, and you should describe the nature of that proposed amendment so that we can get a second.
Okay, so in reading vote number 1, sentence 3 actually is redundant. I think that should be struck because you've already said what you have to say in sentence 2. Sentence 5 is a problem because it's not based on any data that I've seen presented today or read in the literature why we are recommending or providing guidance to our pediatricians and others who administer this dose. Why is it?
Understood. So is there a motion?
Yes. So the motion would be to strike sentence 3 and to strike sentence 5.
Okay, so sentence 3 would begin with the word parents should consult. And sentence 5 would begin with the words for those not receiving. Is that true?
Correct.
Okay, so we have a motion to strike those 2 sentences. Do we have a second? I'm respecting that all members, including our virtual members, are seeking an opportunity to read this and consider whether to second. I'm not hearing a second.
Well, if you have a second, then we can debate it. If you have no second, then you have to drop it.
That's kind of what I'm saying. So I have not heard a second. I thank you, Dr. Pollack, for the motion. Do we have other motions for amendment of vote number 1?
Robert, it's fair.
I apologize that it's taken me a while to thoroughly read this question for vote number 1.
I'm glad you're doing it. Please let it take your time and ensure that you have been able to process the language.
Yeah, this is Cody. I'm having a hard time too. I need to, if you could put it up once again, and maybe Dr. Pollack, how would you like to see it read?
Shall I respond to that, Mr. Chair? Sentence 3, in essence, is redundant because you've got what you need to say in sentence 2. So I'm not sure why we've included sentence 3. Sentence 5, I believe, unfairly, first of all, there's no data to support this 2-month of age suggestion. No one has presented any data as to why 1 month, 2 months, 3 months, or 4 months is a preferred time to administer the first dose. So that if we're here as a science-based committee, there is no data to support this 2-month recommendation. Secondly, if you go ahead and hamstring our colleagues in pediatrics and elsewhere to this 2-month time frame, you're providing what may be a guideline, if it's adopted by HHS, which can then be used by plaintiff attorneys if, in fact, pediatricians and others who administer this dose don't provide it as described in this sentence number 5. So those are the reasons why I suggested these friendly amendments to strike sentence 3 and to strike sentence 5, and I was looking for a second.
Yes, and in sentence 4, I mean, that's true for every vaccine. I'm not sure it needs to be stated here.
Are you referring to the sentence, parents and healthcare providers should consider vaccine risks, benefits risks, and infection risks?
Yes.
Well, that's already said in sentence 2. It's also redundant.
So it's, perhaps this was written by the Department of Redundancy Department. It does indeed say this 3 times. The only differentiation is whether to begin the HBV series rather than just the birth dose. I concur with that, and I concur that I concur with your suggestion to eliminate the 5th sentence as there is no data.
So let me state the motion again for the chair. The chair is looking for a motion and a second. So the motion is to strike sentence 3 and to strike sentence 5, and we're looking for a second. Is there a second to the motion? Dr. Hibbelin, just say yes, and then we can discuss.
No.
It's, I mean, there are several statements that need to, I mean, no, I agree with you in deleting those, but there are other statements that should be deleted also. So, I mean, it would be much easier if we could have a hard copy of this and think about it a little bit, if we could defer this vote, Robert. I don't know if that's an option.
It is, right now, it is open discussion. If you want to make a motion that we defer the vote, that's your right to do so.
Okay, there is a motion on the floor. Does that have to be acted on first?
It does.
What's the motion on the floor?
Yours.
Okay, it needs a second.
Okay, so I don't hear a second. This is a second round of seeking a second. And I'm trying to just facilitate this. Dr. Meissner, so the discussion is now open for additional motions.
Okay, thank you. I would like to make a motion that we have an opportunity to look at a hard copy of the votes and hopefully defer until tomorrow if that's possible.
Okay, make it a little more affirmative. What is it you propose, Dr. Meissner?
I am proposing that we defer voting on question 1 and question 2, and if there is I'm still not sure. Is there a question 3?
There is.
Or and 4?
No,
I would like
just
to see,
3.
Yep, I would like to see all questions under consideration and have the opportunity to think a little bit more about the wording.
Okay, can I rephrase that, sir? See if you concur. A motion has been made by Dr. Meissner to defer voting on all 3 until tomorrow's session. Have I accurately captured your motion?
Yes, you have. Thank you.
Thank you, sir. Do we have a second on that motion? I second. Okay, that's second.
That motion. This is Dr. Hibbelin. I second that motion.
So we have seconds from both Dr. Levy and from yourself. Shall we, then we proceed to discussion. Discussion is now open about whether we shall defer voting until tomorrow morning. I'm going to begin that discussion by noting that our chairperson is about to jump on a plane to go to Asia and would not be available, I believe, for voting tomorrow. But that's just a FYI. Do we have other discussion concerning the proposed amendment to our agenda? Oh, and I noticed that Dr. Hoag is asking to comment. Please do.
Yes, so this is actually regarding adding language about the hepatitis B immunoglobulin in both votes 1 and 2. I actually think that that's unnecessary, and looking at vote 2, it might create a problem just because there's actually different, if I'm understanding this correctly, and now I'm not a pediatrician, and I don't know if Dr. Meisner would want to weigh in on this, but my understanding is that the recommendations differ in terms of giving the immune globulin depending on the weight of the baby if the hepatitis B surface antigen test is not done or the status is not known in the mother, and waiting until you get that information.
Got it. So can you park that for just now,
Yeah.
if you don't mind, because we have a motion on the floor, a live motion, and it's been seconded. So right now the discussion has to do with deferring the vote until tomorrow morning.
Got it. I was just
it's
adding
good.
a little additional information in case that assisted with the
I'm
decision
grateful,
about
but
the
I'm
vote.
trying to.
Sorry.
I'm trying to herd the cats here.
Thanks, Robert.
Do we have additional discussion?
Might I propose that you eliminate the term tomorrow morning and just say tomorrow?
Okay, that can't happen. So,
Okay.
just structurally, and that's so. Cody, I had attempted to capture Cody's motion, which has been twice seconded. Up for discussion is further points about the utility and appropriateness of the motion in terms of our agenda. So are there further discussions regarding that, or shall we proceed to vote? Okay, I'm not sure about Robert's rules here, but I suggest we proceed to vote. So I'm going to call the vote for the motion, which if I can, Cody, please correct me if I get it wrong. The motion at hand is to delay all 3 votes until presumably early tomorrow, but any votes I've just noting have to occur after the public comments. That's just the rules. So I'm going to call the vote on the motion to delay, beginning with Dr. Pollack. And remember that we need to say whether or not you have a COI.
Vote yes, no COI.
Stein.
No conflict of interest, vote yes.
So that's yes, yes. Dr. Levy.
No conflict of interest, yes.
Dr. Pebsworth.
No conflict of interest, no.
Dr. Malone, no COI, and no. Dr. Griffin.
No conflict of interest, yes.
Dr. Blackburn.
No conflict, yes.
Dr. Pagano.
James Pagano, no conflicts, no.
Dr. Meisner.
Meisner, no conflicts, yes.
Milhound. Dr. Milhound, are you available? I think he's maybe boarding the airplane. Dr. Hiblin.
This is Dr. Hiblin, no conflicts of interest, yes to delay the
3,
vote.
4, 5, 6. So that's 6-3. Therefore, the motion passes. Do you concur? Okay, so the motion has been made and passed that the vote shall be delayed until it can be rescheduled tomorrow morning to provide adequate time for members to review the vote language. So with that, moving on to the next.
And may I request that we get that vote language sent to us, please? for all three votes.
I concur that is a necessity, and I believe it's in progress from our liaison to the from the CDC, ergo Mina. So then, proceeding with the schedule for today, we now have eliminated the line item public comments, which was scheduled for 2, and we've eliminated the line item for today, which was votes, scheduled for 2:30. The line item coverage implications, I believe, I asked Dr. Peacock and Dr. Johnson, I believe coverage implications has that both of those are going to have to be deferred until after there's any amendments. Do you concur?
So with regard to my afternoon presentation for coverage implications, it was not specific to the vote, but rather how that functions with ACIP recommendations at large. So I defer to the chair.
Roger, so I'm just trying to figure out what our schedule is now and adapt to the changing conditions. My sense is that we now reinitiate open discussions on the topic areas with the ACIP members and then move to discussions with the liaisons.
Today we commit to stopping decades of violence and bloodshed and to begin a new era of harmony and cooperation between the Democratic Republic of the Congo and Rwanda. I want to thank the two courageous leaders. They are courageous leaders. They really are courageous leaders, great people. President Tshisekedi of the Democratic Republic of the Congo and President Kagame of Rwanda. They are amazing people, and they had stories to tell me that were incredible. Really fascinating in so many different ways. Sad and beautiful, both sad and beautiful, and today makes them beautiful. I've just held really fantastic meetings with both men and representatives of other countries where we discussed the importance of upholding this new agreement. Very detailed, powerful agreement. I also want to thank several foreign guests and dignitaries in attendance to celebrate this magnificent event, including the President of Angola. Please, would you stand? And so great to see you. Thank you. The President of Burundi. Thank you very much. Great to see you again. The President of Kenya. We have the Olympics here. You know, they do very well in the Olympics, those runners. I don't know what the heck you do with those runners, but they are very good. I've been watching them for a long time. So we have the Olympics coming to the United States. You know that. Thank you very much. And you'll come as our guest. Thank you. And the President of the Council of Ministers of Togo. Thank you. Thank you very much. The Vice President of Uganda. Thank you. It's such a beautiful color. Like all these guys are wearing these dark suits. You just stand out for a lot of reasons. You're beautiful. The Foreign Ministers of Qatar. Thank you. Thank you very much. Say hello to my friend, a great man. And the United Arab Emirates, thank you. Thank you. My regards, right? And the chairman of the African Union Commission, who's done a fantastic job, and thank you for all your help. We appreciate all your help. A special group of people. A very special thanks as well to Secretary of State Marco Rubio. Marco, please stand. Thank you. And thank you for putting a certain name in that building. I said, boy, that is beautiful. That blew up last night. They said, that's a great honor. It really is. On this building, it's a great honor. Thank you very much. I assume you had a lot to do with that. Just a little bit. Yeah. Thank you. Appreciate it. And Senior Advisor for Africa, Masad Boulos, who's been fantastic. Thank you, Masad. All of these people, every one of them were indispensable in forging this agreement. Let me also recognize Senators Mike Rounds and Lindsey Graham. Lindsey, thank you. Mike, wherever you may be. Thank you. Thank you, Mike. Representatives Ronnie Jackson. Where's Ronnie? Ronnie is that great guy. He won his race in Texas by 48 points, right, Ronnie? So I don't have to ask if he's in any, I don't even have to endorse him anymore. It doesn't matter. Save the paper, right? Great job. Chris Smith. Chris? Thank you, Chris. Great. Good job. Trent Kelly. Trent? Thank you very much. Thank you. And the acting president of the Institute for Peace, Darren Beatty. Thank you, Darren, very much. Thank you very much, Darren. For more than 30 years, one of the worst conflicts on earth has been raging in eastern Congo. Millions and millions of people have been tragically killed, went on forever, and countless more have been displaced from their homes. Families have been destroyed. It's been a disaster. Many administrations have tried, but probably not too hard, knowing who preceded me. But they tried. It says they've tried. But we tried harder to end this conflict. But they've accomplished, obviously, they accomplished very little because the killing went on at levels that just got worse and worse. And today we're succeeding where so many others have failed. And this has become the 8th war that we've ended in less than 1 year. Such an exciting thing to do. This has been a really, because we're talking about 30 years of fighting, 30 years, much more than 10 million lives. Last June, thanks to the efforts of Secretary Rubio and Mr. Boulos, Rwanda and the DRC reached a landmark agreement to move toward peace. They started the process. I met with some of their great representatives who are here also. And we started a great process. The compact we're signing today, which will be known as the Washington Accords, everybody sort of liked that name, formalizes the terms agreed to in June, including a permanent ceasefire, the disarmament of non-state forces, provisions for refugees to return to their homes, and justice and accountability for those who have committed illegal atrocities. Very importantly, this agreement also creates a new framework for economic prosperity. There's tremendous wealth in that beautiful earth. It's beautiful earth. But it was stained badly with blood, tremendous amounts of blood. But in the region that will support a lasting peace, and the Democratic Republic of the Congo and Rwanda have agreed to more closely integrate their economies with each other rather than fighting, and they'll be doing that. And these two gentlemen are very smart, and I think they liked each other a lot. I spent time with them. I think they liked some people may be surprised. I really do. I think they've spent a lot of time killing each other, and now they're going to spend a lot of time hugging, holding hands, and taking advantage of the United States of America economically like every other country does. So they're going to do very well. But they do have some very valuable things. They're going to have a lot of money and a lot of success, and I think they're going to get along really well, so I hope so. Thank you very much. Look at them. Look at the way they love each other. Thank you. So I have a lot of confidence in both leaders. We'll keep these commitments. I know they're going to keep them and follow through on the agreement and create a much brighter future for the people of their countries. And they're heroes within their countries because of today. This is a big story. And so much is being written and said. All of the newscasts have it at the top of the list. And they are heroes, and we want to keep it that way. Today, the United States is also signing our own bilateral agreements with the Congo and Rwanda that will unlock new opportunities for the United States to access critical minerals and provide economic benefits for everybody. And we'll be involved with sending some of our biggest and greatest companies over to the two countries. And we're going to take out some of the rare earth and take out some of the assets and pay, and everybody's going to make a lot of money. These are just two of the many new agreements related to mineral supplies that my administration has achieved this year, including with Australia, Japan, Kazakhstan, Malaysia, South Korea, and many other countries. With all of these agreements, we're forging new economic security partnerships that protect the interests of America and our friends and partners, and a core feature of my administration's national security strategy, a big part of which is the tariffs. We're taking in trillions of dollars in tariffs. Nobody's ever seen anything like it, and it's given us really great national security. We'll be paying down debt. We'll be making distributions to people, and we're really doing a job. It's amazing. I was with a gentleman, the future king of Saudi Arabia, and you've heard me say this a couple of times, but 2 months ago when I was over there, he said, and actually Qatar is represented today, and UAE is represented, and your leader said the exact same thing, different words, but the exact same thing, that 1 year ago they thought our country was dead, and now our country is the hottest country anywhere in the world. We're the hottest country anywhere in the world. Nobody's ever seen anything like it. We have over $18 trillion, that's just in 10 months, pledged or being invested or pledged to be invested in the United States. Think of that, 18 trillion. The highest amount we've ever had is 1.5. Under the Biden administration, they did much less than 1 in 4 years. Think of that. So they did less than 1 trillion in 4 years. We have 18 trillion in 10 months. It's going to be much more than that, too. No other country in history has ever been close, no matter what country you pick. So I want to thank you again, everybody, for your great vision, and I want to thank the people, especially the people that we named. Some of the others that unfortunately we didn't name, we just couldn't do that. But for your vision and for your courage, because it's made it possible to begin healing old wounds and transcending past differences and creating a future where every child of God can live in dignity, prosperity, and peace. And these are two very good men, and they're two potentially very strong countries. I'd like to now invite President Kagame to come up and say a few words. It's Rwanda. And then, if I may, President of DRC, who really is doing a great job. These are two men that are doing a great job. And again, they are so respected because of what they're doing today and the mission that they've really, I think, accomplished. And we'll see how it all works out, but I think it's going to work out really great. They want to get on to other ways of living for their people, and they're great leaders. Thank you very much. Please, Mr. President, thank you. Thank you very much.
Excellency Donald Trump, President of the United States of America, Excellencies, heads of state and government and former heads of state, distinguished ladies and gentlemen, I want to begin with some words of thanks. First, to my fellow heads of state and government from Africa, your presence here confirms that these efforts enjoy the broad support necessary to succeed. I also thank Minister of State Kulaifi, representing His Highness Sheikh Tamim bin Hamad of Qatar. The role of Qatar has been absolutely central in getting us to this point. But of course, the biggest vote of thanks goes to President Donald Trump. No one was asking President Trump to take up this task. Our region is far from the headlines. But when the President saw the opportunity to contribute to peace, he immediately took it. This conflict has lasted for 30 years. We have seen countless mediations and efforts, but none has succeeded in resolving the underlying issues. President Trump introduced a new and effective dynamism that created the space for breakthroughs. His approach is even-handed, never taking sides. He orients us toward the future, not the past, emphasizing that the dividend of peace is prosperity and investment, including from the United States. More importantly, President Trump's approach is pragmatic. The process has not become an end in itself. All of these elements filter down to his dedicated team, and here I want to single out Secretary Rubio and Masad Boulos for special appreciation. We would not be here today without their efforts. And as a result, we have the clearest and most viable path forward that we have ever had. These accords provide everything needed to end this conflict once and for all. If this agreement falters and things do not work out as they are supposed to, the responsibility will not lie with President Trump, but with ourselves. It's up to us in Africa, working with our partners to consolidate and expand this peace. There will be ups and downs on the road ahead. There is no doubt about it. Rwanda, I know, will not be found wanting. I can assure you of that. Our only objective is and has always been for our country to be safe and secure after having endured so much tragedy. We now only want to look forward in confident expectation of a prosperous and stable future. Mr. President, Excellencies, I thank you for your kind attention.
Mr. the President of the United States, Donald Trump, ladies and gentlemen, dear members of the delegations, distinguished guests, as we have just placed our signatures at the bottom of the joint declaration enshrining the Washington agreements for peace and prosperity, I do feel, on behalf of the people of Congo, a deep gratitude and clear hope. First of all, I would like to express quite solemnly our deep thanks to the President of the United States of America, Mr. Donald Trump. I would like to thank his administration and also wish to thank the American people for the critical role that they played as doing for the rapprochement, the closening between the Democratic Republic of Congo and the Republic of Rwanda. To these thanks, I also bring in all of our regional partners and our international partners who, thanks to their commitment and engagement, have consistently made this critical moment possible in the road to peace. First and foremost, we have Sheikh Yanim bin Ahmad Adani. We have President João Manuel Lourenço Gonçalves, who is the President of Angola and the acting President of the African Union. And we also have the former President of the Republic of Kenya, my brother, Uhuru Kenyatta, who I can see here in the room. These two great Africans who are at the beginning, who started the Rwanda and the Nairobi processes. And beyond them, I wish to thank also all of the African leaders who contributed to help us in this struggle. And I do hope that we have, yes, reached the end. The Washington agreements are not yet another document. These represent a turning point. They bring together under a coherent architecture a declaration of principles of a peace agreement and also the regional economic integration framework to provide to the peoples of the region a new perspective, a new outlook, namely to finally overcome the cycle of violence, of forced displacements, of mistrust, defiance, in order to begin a new era of friendship, cooperation, and prosperity all shared together. For those involved, the Democratic Republic of Congo takes this solemn commitment to implement with complete sincerity all of our obligations that stem from this agreement. We will do this with seriousness, with rigorousness, and also the constant care for peace and the security of our populations, for the unity and the integrity of our territory. We do hope that thanks with the same seriousness that the Republic of Rwanda will also respect fully the letter and the spirit of the commitments made here in Washington. We are reaching out for a peaceful cooperation based on mutual respect, non-interference, and the joint struggle against the armed groups, the end of all support to negative forces, and the beginning of fair prosperity on behalf of our two populations. I do believe this day is the beginning of a new path. A demanding path, yes indeed, quite difficult, but this is a path where peace will not just be a wish and aspiration, but a turning point. The Democratic Republic of Congo will fully play its part with dignity, with consciousness and consistency, and with the support of our partners. We will remain watchful, vigilant, but not pessimistic. We'll be clear-eyed, but resolutely optimistic. These Washington agreements for peace and prosperity must be for our peoples a symbol of an irreversible commitment to turn the page of confrontations and to open a new era of cooperation and sustainable peace throughout the region. Thank you.
So, if I might, my four new friends, a couple of cases not that new. Could you come up, please? Do you mind? Please. They represent so many and so well, so I just want to thank you very much. Good.
Sr. Presidente Donald Trump, Presidente dos Estados Unidos da América, caros convidados, altas entidades aqui presentes, senhores jornalistas, eu gostaria de realçar a importância desta cerimônia aqui em Washington, D.C., que vai finalmente pôr fim a um conflito que, como já foi dito, dura mais de 3 décadas. Não são exatamente 30 anos, mas mais do que 3 décadas. Um conflito entre irmãos, países vizinhos e irmãos, que deviam se dar bem, mas que, por razões de diversa ordem, têm vindo a se degladiar ao longo dos anos, com pesadas consequências, quer para as populações de ambos os países, como também para as respectivas economias. A região dos Grandes Lagos é uma região das mais ricas do mundo, não apenas da África. É enormemente rica em recursos hídricos, terras aráveis, florestas, recursos minerais que estão no subsolo, mas, sobretudo, rico nas suas pessoas, com um potencial muito grande para desenvolver aquela região da África que pode catapultar o desenvolvimento de outras regiões igualmente do nosso continente. O mundo atravessa hoje uma crise energética e alimentar. Nós fomos a dizer que a África, e em particular essa região dos Grandes Lagos, tem o potencial, não digo de resolver, mas de contribuir consideravelmente para a resolução dessas duas grandes crises, quer alimentar, quer a energética, não apenas para o nosso continente, mas para o mundo. A grande barragem do Inga, adormecida há bastantes anos, pode contribuir enormemente para a eletrificação do continente e, consequentemente, para a sua industrialização. Em termos de agricultura, o facto de ter terras aráveis, um índice de chuvas bastante regular e abundante, pode-se desenvolver agricultura naquelas regiões para alimentar o continente. E nada disso tem sido possível fazer-se ao longo de décadas, devido a este conflito que não tem sentido e que, finalmente e felizmente, parece que terá o seu fim hoje aqui.
Brave men and women of the FBI and the interagency. I want to take a moment to thank the Metropolitan Police Department, the United States Capitol Police, our brave prosecutors, the Department of Justice, and our leader, Attorney General Pam Bondi, and U.S. Attorney Janine Pirro, whose relentless work on this case made this possible. As the Attorney General said, we did not discover any new information. What we did, an investigation spearheaded by the Deputy Director and the ADIC of our Washington field office, brought in a new team of investigators and experts, re-examined every piece of evidence, sifted through all the data, something that the prior administration refused and failed to do. As a result of that, we generated numerous investigative leads, executed multiple legal process with our U.S. attorney partners, and came to this conclusion today. And that is why we were able to safely secure this individual into custody. Remember, we are dealing with an individual who is alleged to have made bombs. We cannot do this sort of takedown in haste because it endangers the lives of law enforcement. And this FBI will never allow the lives of law enforcement and our prosecutors to be put in jeopardy. This execution was flawless in terms of teamwork, resilience, and just a good old-fashioned way of police getting the job done. When you let good cops be cops, this is what happens. I'm eternally grateful to the team behind me, to the leadership at the FBI who made this possible. But I do want to highlight, when I introduced the deputy, he made this case and so many others, including Summer Heat, his priority to come in here and solve it for the American people. And today, I'm proud to stand here before you and say, we solved it. He will have his day in court. The American public and the world will learn even more information through the legal process. As we have committed under this Attorney General, we are the most transparent law enforcement operation in U.S. history, but we are also going to make sure accountability is delivered to its fullest extent, and that happens in the courts of law with our U.S. attorneys and our prosecutors. So we will divulge information when it is prudent and constitutionally permissible, while upholding the safeguards of this case to make sure that the people that this individual intended to victimize get the accountability they deserve, and most importantly, to deliver on President Trump's promise to secure our nation's capital and the rest of the cities in this country, to make sure that Americans are allowed to go out free and securely in their neighborhoods, and that people around the world are allowed to visit our nation's capital, and they now have that trust thanks to the leadership of the FBI, the Washington field office, and I'm honored now to introduce to you Deputy Director Bongino, who spearheaded this investigation.
Thank you all for being here for this critical investigation we've been working on for a very long time. We deeply appreciate it. Thank you for the kind words, Attorney General and Director. I appreciate it. Folks, this is what it's like when you work for a president who tells you to go get the bad guys and stop focusing on other extraneous things not related to law enforcement. This is what happens. We had a great team. I know it's said a lot in this business. It was a team effort. It becomes cliche, but cliches are useful for a reason because they matter. And this was a team effort. The Director and the Attorney General emphasized that it was not a new public tip this came from. This was our internal work at the FBI. And I want to just really express my sincere gratitude to this Attorney General and this President for allowing us the latitude. I spoke with Ms. Bondi very early when we, maybe day 2, and I said, we're going to get this guy. And she said, yes, you are. And we did. I want to also thank, he's not here, but Deputy Attorney General Todd Blanche, who we deal with often as well, who could not have been more supportive. Whatever process we need, Judge Janine, Todd, and Attorney General Bondi, they were there. All you had to do, they were a phone call away. And their team was amazing. We actually never had to make that phone call because they were always responsive. Thank you, Judge, as well. You were amazing. Folks, you're not going to walk into our capital city, put down 2 explosive devices, and walk off in the sunset. Not going to happen. We were going to track this person to the end of the earth. There was no way he was getting away. Well, we didn't have to track him to the end of the earth. It wound up in Woodbridge, Virginia. I want to thank the team. They were amazing. They never let this go. Again, Attorney General Bondi, for your incredible support. Director Patel, Judge, I know they're giving me a lot of unnecessary credit, but make no mistake, they were intimately involved in this and were there for all of those supportive mechanisms, and I deeply appreciate it. The man whose team did the work is the Assistant Director in charge of our Washington field office, Darren Cox. Darren's got some comments, and Darren has some more details on the case he can provide. So thank you all for coming. We appreciate it.
Hi, good afternoon. I'm Darren Cox. I'm the Assistant Director in charge of the Washington Field Office. Today's arrest of the alleged D.C. pipe bomber is a momentous day for the American public, for the FBI, for our Joint Terrorism Task Force, or the JTTF, and our partners, the U.S. Capitol Police, Metropolitan Police Department, and ATF. We've also had a large number of other federal, state, and local departments that have worked on this investigation. And last but not least, the U.S. Attorney's Office. We all worked hand in hand to solve this investigation. This has been a long week in D.C. After the terrorist attack last week, the grit and determination of the FBI and our law enforcement partners is an example to the American public of what cooperation, partnership, and selfless service can accomplish. The amount of effort the FBI and our partners devoted to identifying the pipe bomber cannot be overstated. It is the resolve and determination of our investigators that ultimately led to the identification and the arrest of this suspect. We all know pipe bombs are dangerous, not because of the potential loss of life, damage to property, or injury that they can cause, but also because they are tools that terrorize our community. Fortunately, these bombs did not explode, although they certainly could have. But make no mistake, the alleged pipe bomber did terrorize our community. Today's actions underscore the long memory and the long reach of the FBI and our partners. I know some people had given up on finding the perpetrator, but not the FBI and not our partners. We do not forget, we do not give up, and we do not relent. Though it had been nearly 5 years, our team continued to churn through massive amounts of data and tips that we used to identify this suspect. I want to thank Director Patel and Deputy Director Bongino for their leadership and for providing us the resources and the personnel to reevaluate all of the data that we had. We dove into more than 3 million lines of data to come up with this suspect. Director Patel, Deputy Director Bongino, thank you for your support, thank you for your passion, and thank you for your investment in this investigation. From me, on behalf of the investigators, the Washington Field Office, and all of our partners, thank you. I'd also like to thank Judge Pirro. Judge, your team and you are absolutely amazing. You're the type of prosecutors and U.S. attorney, that all of the investigators across the country want to work with. They're hard-nosed and they're aggressive, and thank you for that. I'd also like to thank the American public for providing tips and leads, not just on this case, but every day on cases across the country that are being solved by law enforcement. And finally, I want to commend all of the members of the Washington Field Office, and most specifically, the investigative team. Their diligence and persistence led to this arrest today, and they are absolutely, totally dedicated not only to this case, but every case they work. So thank you, Washington Field Office. Last, I will say our work is not done. The FBI will continue to pursue every lead and use every resource that we have to ensure that the D.C. pipe bomber is brought to justice. Thank you.
You keep hearing the words partnership and team, and that's what we are. And we could not do this without our U.S. Attorney, Jeanine Pirro. Jeanine, from day one, has worked tirelessly for our country and for our nation's capital. It's my honor to introduce my friend, U.S. Attorney Jeanine Pirro.
Thank you very much, Attorney General. And you have been listening to a lot of thank yous and a lot of gratitude. The reason that we're thanking each other to the extent that we are today is because we have seen in this case an incredible collaboration around the clock, in the middle of the night. It doesn't matter. We call each other, we make contact, they need a warrant, they need something, someone wants legal advice. These are the men and women who never give it up. You hear about government employees, but I don't know if you really realize what it is that they do. They are incredible, and this case is big. 4 years, 10 months, and 28 days ago, an individual placed a bomb in the vicinity of both the RNC and the DNC. And for that amount of time, that individual evaded accountability. Today, as a result of the cumulative efforts of the men and women in the FBI and the police department and the Department of Justice, we are finally able to make an arrest of an individual by the name of Brian Cole. As the Attorney General has indicated, he is arrested for transporting an explosive device in interstate commerce, as well as the attempted malicious destruction by means of explosive materials. You know, folks, this case involved millions of pieces of data. And it is a huge win because it was like finding a needle in a haystack. So much of this evidence was very specific, but a lot of it was also very general. For example, there were 233,000 black end caps of the type that were used in this case. I want you to think about the fact that the FBI had to go through the sale of every one of them to try to find commonality with an individual, along with the purchase of the pipe itself, the cap ends, the wires, the steel, and the 9-volt batteries. Every one of those had to be mined and remined to the point where we were able to then connect. And make no mistake, it was this administration, it was this president who made the decision that we were going to use all of our efforts to get it done, and get it done they did. Finally, let me say this. Today begins the formal process of accountability, where this defendant will begin his journey through the criminal justice system. And I pledge to you that the United States Attorney's Office will take this case across the finish line. Again, thank you to the incredible work of the FBI, to the Attorney General, and to our local partners as well. This is a job that I think was well done.
Thank you. President Trump's directive to all of us was to not only make America safe again, but D.C., and to make it safe and beautiful. We could not have done that without our partnership with Mayor Bowser and Chief Smith. It is my honor to introduce Metropolitan Police Department Chief Smith.
Good afternoon, and thank you, everyone. I am Chief Pamela Smith, Chief of Police of the Metropolitan Police Department. Thank you, Attorney General Bondi, U.S. Attorney Jeanine Pirro, and FBI Director Patel for having me here today. For nearly 5 years, the agencies standing here today have worked together under the leadership of the FBI to locate our suspect who is responsible for the 2 pipe bombs that were placed around our city. MPD members assigned to the FBI's Joint Terrorism Task Force have supported this case from the beginning. That supports include looking, reviewing, and going through countless, probably thousands of hours of CCTV footage from around the DNC and RNC headquarters, and they followed up on hundreds and thousands of leads from members of our communities. What I will say today is that Washingtonians can rest easier today knowing that the suspect responsible for this act is now in custody. This morning's arrest is yet another reminder that committing any act with the intention of harming the residents and visitors of the District of Columbia will result in your arrest. the men and women of the Metropolitan Police Department, the FBI, the ATF, the U.S. Capitol Police, and certainly the prosecutors at our U.S. Attorney's Office will go to the furthest length. I heard somebody say to the end of the earth, but thank God we didn't have to go to the end of the earth today, that we were able to bring this subject into custody. I want to commend the men and women of the FBI and the members of the Metropolitan Police Department and all of the agencies who are standing behind me today on a job well done. I will turn it over now to Attorney General Bondi.
We're going to take some questions. Just remember, as I said in the beginning, this is ongoing. It's very active. The search warrants are still being executed. Many charges potentially to come. So just keep that in mind when asking your questions.
Jake, Fox News. So you said it had been nearly 5 years, we all know that, and that you said there have been no new evidence. So can you say anything about the evidence that actually did lead to this arrest? And then secondarily, you're talking about additional charges possibly. Can you say what those you might be considering, or terrorism charges, or what?
We can't discuss new charges, of course, yet, ongoing. But what I will say is this is why this was so incredibly important, more than any other case, is this is in our nation's capital where this happened. And now, thanks to the FBI, we know that this defendant was living just miles away from here in Virginia. So as to the evidence in the case, I'm going to let Director Patel take that, but it's still very active and very ongoing.
Thank you, General. And as I stated earlier, and as the General has already reiterated, our job is to provide full accountability in the court of law with Judge Pirro's team. And in order to do that, we have to preserve the chain of custody and evidentiary value. What I will say generally is that when you go through 3 million lines of information, y'all can think about the amount of cell phone data that has to be ingested and triangulated and dumped and received. You also have to think of just sheer human ingenuity. We brought in a team of experts who were the best at what they do in their specific fields to reevaluate that evidence, to dive back in, and to not come back with a no for an answer until they had found the suspect. And when you develop evidence, you get a search warrant. And when you get a search warrant, you get an address. And when you get an address, you hit the house. And that's what we did.
Sadie, Wall Street Journal.
Hi there. So what can you tell us about this person's motivations and whether they were driven by politics or for any other reason why?
Right now, it's ongoing. Again, we just executed the search warrant early this morning. It's ongoing. But America's safer, DC's safer because he's in custody.
Mary Margaret, Daily Wire.
Thank you so much. So, any theory on why Kamala Harris has never mentioned coming within 20 feet of being assassinated, and any news on why her Secret Service team took so long to find this bomb at the DNC?
No, but what I will tell you is that evidence has been sitting there collecting dust. This wasn't a new tip. It wasn't some new evidence. It was the hard work of President Trump's administration, Deputy Director Bongino and Director Patel. I watched them from day one come in here and say, we are going to solve this crime. And they did, working hand in hand with U.S. Attorney Pirro and all of our great attorneys.
Pierre, ABC.
General Bondi, Director Patel, or Deputy Director Bongino, can you describe, was there a particular moment where the evidence is coming in and it's starting to look like progress is being made? What was the moment that you knew that you were on the road to solving the case?
Dan, you want to take that?
Yeah, sure. I was smiling at you because I certainly remember the moment. Darren remembers it too. He said, "Are you sitting down?" Called me on the phone. I said, "Oh boy, why? Is this bad news?" And he said, "I think we got him." What exactly that tip was, we're going to have to pass on that for right now while we're still, obviously we're in the prologue of a long book. This is just the beginning. This is not the end of the investigation, as you all well know, having reported on these for a long time. There's interviews to be conducted. The search warrant processing scene is not even done. So we're at the early stages, so that's the only reason I hesitate to tell you what the exact tip was. But yes, that was absolutely the moment, and it was due to the diligent and incredible work of a team in the Washington field office that came in and just scoured through this over and over and over and over again.
In general, was it forensic? Was it a phone call? Was it something about a vehicle? Just in
I'd rather,
general?
we'll just leave it generally forensic evidence. Yeah, it's fair enough to say.
Excuse me? How long ago that was?
I'd rather not say because of the ongoing interview process, and I don't want to. Yeah, yeah.
I just want to add something to tell you how thorough this team was. That moment that was kind of like the aha moment, that wasn't the end. This team continued to work and work and work to get every bit of evidence that we could get. We didn't stop at that moment, and that's a testament to the fact that the team wanted every possible piece of evidence that they could gather.
One more?
Should we one more, Kelly O'Donnell and Lisa?
Thank you so much. Have you recovered the notable sneakers? Have you done surveillance of this suspect from that aha moment to when you exercised the search warrants today? And obviously this happened on January 5th into January 6th. How should the public look at this case separate from all of the cases related to what transpired on January 6th and the president's subsequent pardons?
I'm going to let Director Patel take the evidence part. We have to be careful. Again, you've asked very good investigative questions, but this is ongoing, very active. But America should feel safer today. We say a pipe bomb. These are bombs. These were live, active bombs that were placed in Washington, D.C. Director.
Thank you. This shows you how much detail you and the American public have paid attention to this case. Of course, we analyzed everything that you're seeing on this poster board and information that you will see through the formal charging process and court process. But we want to let that evidence speak for itself because, again, we do not want to disrupt the accountability that we owe the American public. Yes, you heard about the cell phone tower data. Yes, you heard about, of course, we surveil individuals who we think we're going to blow up American citizens. But how and when we do it and why we do it is not something we're ever going to reveal unless the Department of Justice deems it fit at trial. So we appreciate your attention to detail and your hardcore investigative work, but you can just imagine some of those same skills were being utilized by this FBI, this Department of Justice, our partners, the ATF, and everybody across the board, and this is an interagency win for the American people.
Radar before.
Thank you all. And one more thing, this is the best birthday present I think Deputy Director Bongino could ask for today. Happy holidays, Merry Christmas. Thank you.
So unfortunately, it's something where I wouldn't be confident that we knew what the impact of a change was for many years.
Robert, can I? So thanks for both the question and the answer. I just want to share a few observations. So I understand that there are some potential long-term consequences. I just want to kind of maybe highlight the potentially different approach that we apply to the safety versus the benefits. When it comes to the risk from the disease, if we don't see something and we cannot measure it, we are always worried. We model, we think that maybe it's more than what we think. Although, frankly speaking, I think that most of these, especially chronic illness, over 30 years, we should have seen already the impact of the universal dose, which again, I don't think we see that. When it comes to safety, for some reason, only the risk from the disease can be long-term. For the risk from the vaccine cannot be long-term, and I find it a puzzle, a logical puzzle, because I think that the whole idea of vaccines is to change, hopefully positively, our immune system for the long run. But if you accept that principle, you have to also assume and consider at least that not all the changes might be positive. And so I just want to highlight the fact that, again, I think it's a good question to ask ourselves. Let's say we didn't have all of these policies in place. There would be new policy to consider. I think if we would look on the current evidence, if this was a new policy, if I listen to the recent FDA declared standard, I don't think that these vaccines would be authorized for the use. We would consider the evidence on safety, potentially efficacy, especially for the Hep B negative moms. We will consider them not passing even a minimal threshold. So respectfully, I would like to kind of to call out the fact that what we are doing here is trying to undo some really, really bad decision processes we had in the past. And we mentioned clinical trials and randomized control experiments. I actually think that in this particular case, when you think about the low risk for babies that are born to Hep B negative moms, you can actually run large clinical trials and long-term clinical trials to understand whether 1, 2, or 3 doses are sufficient, to understand different timings. This is something that there is no ethical reason whatsoever not to run those experiments. And I think that maybe we are not voting on this, but I think this should be a collective call for action for the regulatory agencies across the board to run those experiments, because we want to know the answer, because we want to be able to come to parents with far better information than what we are able to give them today. And I think that hanging into the really bad decision processes that we had in the past is not convincing to parents, or at least to many of them. And it's not convincing to the public. And I think that the recent, again, I'm going to talk about another vaccine, the recent discoveries that we had, that very confident promises about safety of vaccines turn out to not be true, to the extent that children with very, very low risk from SARS-CoV-2 were vaccinated and died. And that was denied, and I think that we really don't want to have many more cases
This was supposed to be liaison time, respectfully. The ACIP members had their chance, and you said this was
I know you want to give
I
know you want to give another speech to tell us how good we are. But
respectfully,
with all due respect, without
evidence, just anecdotes.
Thank you, Dr. Goldman.
Liaison time.
Can we? I understand that there's tensions here, but I want to respect. Remember, this is primarily focused on the informing the ACIP committee. So I'm noticing that Dr. Hiblin has patiently awaited a opportunity. Joe, can you be concise, please, because we have 2 minutes until we close comments.
Yes, sir. This is regards to the question of whether we have evidence of efficacy, and I refer to Dr. Pebsworth and Nebison's charts regarding the decrease in illness in 1991, prior to 1991 and universal vaccination, It was attributed to both the increased use of the vaccines and public health measures, but we can compare that as a single variable change. When there's universal vaccination, the rates of cases went from 17,500 to 601. So when we consider universal vaccination as a single variable that changed, we have a decrease between 17,500 in 1991 to 601 in 2025. Thank you.
Interesting analysis. So we have barely time for Dr. Halbritter. Can you, are you there, Dr. Halbritter? Okay, noting Dr. Resnick, Barbara Resnick. Dr. Robinson, Candace Robinson. Dr. Carolyn Ha. Dr. Laura Morris.
Hi, can you hear me?
Yes, ma'am.
Hi, I suspect some of the other liaisons may have lost the ability to speak. I'm representing the American Academy of Family Physicians and a practicing family doc with full scope care, including prenatal care, practicing in a rural area. My concern and that of my colleagues is the shift from recommending, especially to a schedule that does not have any additional evidence to support moving, for example, to not give a dose prior to 2 months of age, and the impact of moving to shared decision making on the clinical implementation in primary care practices such as myself and for pediatricians and family physicians everywhere.
So, Dr. Morris, what would be that impact? Please educate us.
Sure. The recommendation itself, and having a blanket recommendation for something that has evidence to support that there is benefit that outweighs the risk for the vast majority of patients, moving to shared clinical decision making, and then the required documentation of that, for example, in my area, when the practice changed and the recommendation changed for COVID vaccine, for example, there now are multitudes of messages and prescriptions that are necessary to generate. Pharmacists in my state are tied to ACIP recommendations in such a way that they are required to also document and require prescriptions for many of the places that previously we were able to have standing orders and protocols that vaccinated patients, where we know the benefit outweighs the risk for administering vaccines to those groups, for example. So that is one example, the vast amount of time and undoing a program that is successfully preventing chronic illness and serious ramifications and disease in patients, and undoing that and moving it back to something that requires more documentation and more administrative burden when there is not evidence sufficient of harms to undo the program, and there is not evidence to support the language in the votes that was concerning about moving to specific additional timeframes that have not been evidenced either. So taking something that is successfully preventing disease and moving to something with more administrative burden at a program that does not have evidence to support moving to that time interval or what the outcomes of that model would be is concerning.
I follow and very much appreciate your argument. Can you share, I'm sincerely interested in your perspective, I think we all are, as a frontline physician that is tasked with implementing these things. Can you comment on the implications or burden on an individual parent who wishes to have the latitude to make a go, no-go decision on receiving a product under informed consent versus the mandated environment that has been historic? Can you comment on the implications for the parent?
As speaking on behalf of those primary care physicians and on behalf of the parents and families we interact with right now, I provide, to the very best of my ability, informed consent for parents and families right now. So a recommendation that allows us to say, we strongly recommend this vaccine because we think that this is the best way to protect your baby. And a parent who says, I understand, I've been informed, I have a previous child, I've read, I've done my research, I trust your recommendation, and we can move forward with standing order protocols and other things that we know increase vaccine uptake and help protect our patients with the most streamlined and efficient workflow processes is extremely beneficial to the implementation side. When parents have questions and concerns and we provide written material, we provide counseling prior to the offer of the vaccines. I provide counseling for my prenatal patients as well about what to anticipate in the hospital. And as we've seen,
I appreciate what you're saying,
only
but it's
80% of parents actually were receiving that Hep B vaccine at the birth dose. It's not a mandate. It is already possible with the language and the recommendations
I understand,
the way that we have standing for them to decline.
What I hear is you sharing with me the experience of the parent who endorses current policy. Do you have experience with those parents that are vaccine hesitant for whatever reason, or do not wish to accept the current schedule? Do you have experience with those, and how does this impact on them?
Yes, I absolutely have experience with those parents and those families. And the current recommendation and making a recommended dose at birth does not in any way impede those parents from being able to decline the vaccine at that point, or at any point, or to never vaccinate their child if that is their choice. They have that option with the recommendation the way that it currently stands. And I empathize with parents, and I attempt to answer their concerns and listen to where their concerns are and partner with them. And my recommendation to all my families is that we will absolutely honor your decision making as a parent and bodily autonomy as patients to do what you wish. But this recommendation allows us to best serve the majority of our patients who do wish to vaccinate and understand that protecting their infant from the get-go means that there is very much less chance of even a low risk but catastrophic illness to happen.
Dr. Morris, I sincerely thank you for sharing your frontline experience and insight into these different examples of different categories of patients. I'm honestly grateful for that, but I'm now in the in real time. I'm being updated about our timeline, and so this I have the opportunity to ask Judith Schley to share with us her point of view. Dr. Schley.
Hey, thank you very much. I've been waiting a long time to talk. So a couple of things I wanted to bring up. Number one is I wanted to bring up to the group a recent study that came out just the other day called the Economic Evaluation of Delaying the Infant Hepatitis B Vaccination Schedule by Eric Hall et al. And it looked at not just the economic implications, but also the number of infections that would occur by delaying the dose from birth to 2 months, being 238 additional doses in children. These are mothers who are hepatitis B surface antigen negative.
Did you just misspeak? Did you mean to say 238 additional cases?
Yes, yes. It's in the paper, and I think it should be looked at before we make a decision about changing the implications for the Hep B dose at birth. The second thing I wanted to bring up was that I think that while I agree with the obstetrician on the ACIP panel about changing clinical practices to have a hepatitis B surface antigen test at the time of delivery, I would say that we should not change the birth dose until we have implemented those clinical changes, because then we're sort of, because that will be delayed, and to change clinical practices take time. And the third thing I wanted to bring up was Dr. Nevison's discussion about risk factors and saying they had been decreased. If you look at current risks associated with syphilis, we have seen increases considerably over the last few years, with congenital syphilis going up. So we know that risks are going up precipitously, and that we have to take those into consideration. And the last thing I want to bring up is any child who gets a hepatitis B infection because we change policy is one too many. And we really do need to think about that. I run an immunization program. I represent public health immunization programs throughout the state, the country. And I want us to make sure that we never have any child get hepatitis B infection. Thank you.
Robert, can I?
Yeah, I was waiting for.
Yeah. I just very quickly three thoughts. First, I'm very glad that you mentioned that paper. I actually read it yesterday, and it's actually good that you mentioned the economics. In fact, I think that it's too bad that we never had an economics analysis of cost benefit of this vaccine, because I think we would see, in all likelihood, that it's highly, highly non-economic, in the sense that if we would take the same resources of millions of doses that we give to babies that are at extremely low risk, and instead invest them in better screening, better going after the high-risk population, we're probably going to get much better outcomes overall. I also want to, again, reflect my experience as a parent. And again, I don't want to imply that the physician that we heard talking is part of that. I'm sure she's dedicated, and I've worked very closely with a lot of physicians that are just amazing for their patients. So I have tremendous appreciation to the hard work that they have to do every day, and how critical they are for, to ensure the health of families and children in particular. But unfortunately, I think that even the information that is being communicated to doctors, to medical professionals, and then they communicate that to patients, is not, more often than not, is not based on facts. We basically, since we vaccinate everybody today, or almost everybody, right, we don't really have a control group that we can actually look even retrospectively and trying to understand what are the long-term risks of this vaccine. So we used really outrageous clinical trials. We then decided to go and vaccinate basically every child. And now we are in a position where we tell parents very confidently, and also the doctors, but to medical professionals very confidently, that the vaccine is safe, then there are no problems whatsoever. And I don't think that that's a very, very reliable statement, if I may say.
Can I really quickly say, to your point, in medical school, you are taught this is the pediatric vaccine schedule, and we just memorize it. So you just dropped a truth bomb. There is a cognitive dissonance. I mean, we are given a schedule, and as medical students, you finally make it to medical school, and you do trust that this has been fully vetted to the nth degree. And I myself was shocked to look at, in September, we were presented a safety study from 1993 that had one sentence said, no adverse effects. And you look in the methodology, there was no description on how they had assessed for adverse effects. And these were the studies that were going in to assess safety. Anyway, so to your point, yes, there is a problem, systematic problem going back into our education. I fully believed that this was vetted very well. The safety studies are not that ironclad.
I did want to make a quick comment about the cost-benefit analysis, actually, because there was an extensive, over 100-page cost-benefit analysis published by the Danish government, looking at whether or not it would make sense to introduce a recommendation for universal Hep B vaccination among children, and they found that it did not come close to making health economic sense, and that is actually that's the written reason for their justification for not recommending universal Hep B vaccination at birth or for children at all, in Denmark and identifying groups that they see as high risk and then making that shared clinical decision making, but also making it clear to the public which groups they would see as high risk that may warrant vaccination of children in Denmark. And I'm not trying to give away what I'm talking about tomorrow, but I am going to be talking about that study and that topic tomorrow, not just for the hepatitis B vaccine, but the vaccination recommendations in general in Denmark. So,
I have one quick
No,
comment.
can I quick, please.
Oh, I was just, thank you, Dr. Morris, for giving us.
And they have similar hepatitis B, almost very similar hepatitis B prevalence in Denmark as the United States has of chronic hepatitis B and among surface antigen positive mothers. Just FYI. Sorry, I wanted to add that since I just mentioned
Hillary.
it. It was important.
Yeah, just quickly, thanks, Dr. Morris, for sharing your frontline experience and working with parents. I have heard from numerous parents that have been kicked out of pediatrician practices, and I do have concerns about that. So I know we don't have any data on what that looks like across the country, but definitely have some concerns about parents who want to take different approaches and then have no other options because they aren't given that option. So.
Okay, I'm next going to call again on Dr. Adam Langer of CDC to speak to the Kedong hepatitis B intervention study. Sir.
Yes, thank you so much. Just want to circle back to some comments that Dr. Hoag brought up, I think. I apologize if I'm misattributing. With regard to the issue of whether or not there have ever been any long-term clinical trials that look at what the outcomes and sequelae of hepatitis B vaccination are more than a few days or even a few months. And in fact, there is a trial that was published out of China that has looked at that has basically what happened was there was a shortage of vaccine in the mid to late 1980s, and so the Chinese government had to make decisions about which children in the cohort were going to be given an early age dose and which ones were not. So obviously when there's a lot of vaccine available, you would never want to do that. But in the shortage situation, it made sense, and they sort of treated it as an opportunity to study this question. And then later on, the group that did not get the vaccination series in early childhood was offered the vaccination series in adolescence. So you end up with three arms that you're following through time. One is the group that got the vaccine series very early in life, the group that got it in adolescence, and then the group that never got it. And they actually have been following these individuals for, I think, 35 to 40 years now. And what they have determined, number one, is that they are, one of their main outcomes is they're looking at primary liver cancer caused by hepatitis B virus. And if you look in the two vaccinated arms, especially the arm vaccinated early on, you see that the incidence of primary liver cancer in those individuals is considerably lower than the incidence in the individuals that were never vaccinated. So this just gets to the question that was brought up about what is the true length of efficacy of the vaccine. And there were some observational studies that were presented back in September, but there was some discussion earlier today about, well, is there actually a randomized controlled trial? And the answer is actually yes. And we have sent over the PDF of that article for the committee members to peruse overnight if you would like. The other point with regard to that study, getting into the discussion that we had about, well, if we want to talk about long-term efficacy, And Dr. Levy, this is actually something where I think you and I agree, so perhaps we should note that for historical purposes. You also do need to look at the possibility of adverse events long term. And so that while they haven't published it, the group that is following the individuals, these arms in this controlled trial, is observing for any evidence of a differential in adverse events occurring between the vaccinated group and the unvaccinated group. And based on the information that I have been given, they have not found any reason to believe that the vaccinated group has any higher incidence of a particular adverse event than the unvaccinated group. So the data are actually available. They're not US data, so it's not ideal, but it is from another very large industrialized country.
A brief follow-up with the negative group. So negative at initial vaccination and then negative in follow-up. Is there a possibility of a selection bias because they're essentially non-compliant with the availability of the vaccine when it became available? Over.
So my understanding of the study is that the assignments into the arms were made at the village level, and so because of the fact that this that each village was randomized into receiving the vaccine or their young child cohort receiving the vaccine or not receiving the vaccine, you would not expect to see any selection bias.
Roger, thank you. Next, I call people with lived experience. Are we going to proceed to that? So I apologize to our affiliates that I now, facing the timeline crunch, have to proceed with listening to those persons' perspective that have relevant lived experience. How do we kick that off? Shu Wang. Shu Wang, are you available?
Yes, hi.
Thank you. Please proceed.
Great. Thank you for the opportunity to speak today. My name is Dr. Sue Wang, and I'm a physician living with hepatitis B. Hepatitis B is often discussed in numbers, but let's remember the people behind those numbers. There are countless stories of families, mothers, children, and generations whose lives have been changed by a virus we now have the tools to prevent. Today, I want to share some of those stories, my own stories I hear from families across this country, and our collective story. My mom likes to tell the story of my birth. They had taken a nice walk on Pensacola Beach in Florida, my hometown, and later that night, her water broke, and they rushed to the hospital for an emergency C-section. Because of her recovery, my grandparents stayed to care for me for a month. Only not that long ago, I learned that both of my parents, one a dentist and one a midwife, had gotten hepatitis B at some point and did not know at that time. I likely acquired it from them during that first month. Maybe it was some caregiver moment, like a small cut while handling my rash, or through trimming my nails and there was microscopic blood on that clipper. If there had been a universal birth dose at that time, I would have been protected. Of note, neither my sister nor my parents got hepatitis B from me. Much later, they were tested, vaccinated, and protected. This underscores how uniquely vulnerable infants are. If infected, 90% develop lifelong infections like me, compared with 10% of infected older adults and kids. I see patients with hepatitis B every day, and I hear stories from around the country. Newly diagnosed young adults who feel hopeless. Adults with no risk factors who are born in the U.S., the families have been here for generations, and they carry shame about being infected and worrying about dying early. Children who have lost their parents in their 40s to liver cancer, wishing that their dads were around for them as they grew up. Mothers who feel guilt and worry about their children's futures. These stories have shaped our national response and the decades-long focus on preventing childhood infection. Globally, we're in a race to hepatitis B and C elimination. This is a goal we can reach by 2030 if we implement all the right tools which have been discussed. From my experience coordinating hepatitis B programs and as a mother, all these pieces, maternal testing, antivirals, identifying status at the hospital, giving vaccine, H-big after birth, and then testing the baby after they finish the Hep B vaccines, they involve really complex logistics. As a patient, I often had to tell people what tests to order for me and to make sure nothing was missed. I tasked my husband with his one job at the hospital to make sure our babies got birth dose before 12 hours because I had seen it missed in other kids. The health department had to call my pediatrician to remind them to order my kids' antibody test after vaccine series. Yet in the US, only about half of at-risk infants get this test to confirm they are protected and not infected. You can imagine there are many misses in our healthcare system, and risk-based approaches will create even more gaps. Ascertaining family members' Hep B status and history is not easy. It has taken me literally decades to piece together my own history, and I only very recently found out that my grandfather actually died of liver cancer. We already have recommendations to test women with unknown status at delivery, but gaps remain, especially in precipitous deliveries like my own, where there wouldn't be time to wait for results. If we delay the birth dose for 2 months, estimates predict 1,400 new infections, 482 new deaths, and an extra $222 million in healthcare costs a year alone. Our country has been a leader in Hep B prevention. The birth dose is now adopted in over 116 countries and growing, and only 33 do selected vaccination. While Denmark has great stats, they are not us. They have a universal healthcare system and have less than 20 acute Hep B cases a year. The US is more than 50 times their size and population, much more diverse, and we have a complex, not coordinated healthcare system. We also have more than 14,000 acute Hep B cases a year compared to their less than 20. I myself am a big supporter of shared decision or individualized decision-making with my patients. It's really important when options are equally reasonable. But in preventing hepatitis B transmission for a lifelong disease, the evidence is clear. Timely birth dose is a best practice, and it should remain our recommendation. And as always, there is the choice to opt out. My 4 children all received their Hep B vaccine and are Hep B free, which I'm eternally grateful for. But they would have been covered by a targeted strategy anyway. I'm here to advocate for all children. We cannot predict a child's future risk. Like seatbelts, our overall risk of getting into an accident are low, but we universally wear them because we cannot control the world around us. So let's do the same and continue to universally give every infant a hepatitis B free future. Thank you.
With appreciation and respect, thank you for sharing that. Michael Belkin, are you there?
Yes, can you hear me?
Yes, sir.
Okay, my name is Michael Belkin. I'm a graduate of the UC Berkeley Haas School of Business. Dean Rich Lyons, who is the dean, made the status, he said, question the status quo is the founding principle of UC Berkeley Business School. By the way, Dean Rich Lyons is now the chancellor of UC Berkeley. I'm a guest speaker occasionally at the business school. I have a background in statistics. I advise financial institutions with my models that I developed. And I'm at the Pierre Hotel actually at an investment conference at the moment. If you hear background noise, I apologize for it. So my daughter, Lila Rose Belkin, died at the age of 5 weeks, about 15 hours after receiving her second hepatitis B vaccine booster shot. Lila was a lively, alert 5-week-old baby when I last held her in my arms. Little did I imagine as she gazed intently into my eyes with all the innocence and wonder of a newborn child that she would die that night. She was never ill before receiving the hepatitis B shot. At her final feeding that night, she was extremely agitated, noisy, and feisty, and then she fell asleep suddenly and stopped breathing. The autopsy ruled out choking. The New York medical examiner ruled her death sudden infant death syndrome, SIDS. But the New York medical examiner, Dr. Persicino, neglected to mention Lila's swollen brain or the hepatitis B vaccine in the autopsy report. It was ignored. The coroner spoke to my wife and our pediatrician, and notes of the conversation were brain swollen, not sure cause yet, could not see how recombinant vaccine could cause problems. SIDS is a diagnosis of exclusion. It wasn't this, it wasn't that. everything has been ruled out and we don't know what it is. In other words, they don't know. A swollen brain is not SIDS. Therefore, we had a falsified pathology report. Through conversations with other experienced pathologists, I subsequently discovered that brain inflammation is a classic adverse reaction to vaccination. Look it up in the Merck manual. It's the definition of a vaccine reaction. I set out to do an investigation of the Hep B vaccine and attended a workshop at the National Advisory Committee on Immunization Practices, February meeting, and a debate in New Hampshire. I also obtained the entire vaccine adverse events reporting system, VAERS, database on hepatitis B vaccine reactions and have investigated thoroughly. These are my conclusions supported by the following pages of text and analysis that's in my testimony, written testimony, which I submitted. 1, newborn babies are not at risk of contracting the hepatitis B disease unless their mother is infected. Hepatitis B is primarily a disease of junkies, gays, and promiscuous heterosexuals. The vaccine is given to babies because health authorities couldn't get those risk groups to take the vaccine. Adverse reactions outnumber cases of the disease in government statistics. Nothing is being done to investigate those adverse reactions. And I stand here testifying on behalf of all the others who have had the same problem. Those adverse reactions include numerous deaths, convulsions, and arthritic conditions that occur within days after hepatitis B vaccination. The CDC is misrepresenting hypothetical estimated disease statistics as real cases of the disease. The ACIP recommended new vaccines for premature infants without having scientific studies proving it is safe. I submitted a FOIA, Freedom of Information request, to the CDC along with the Association of American Physicians and Surgeons, Jane Orient, who was the head of it. They never responded. They never gave us the data saying that there were studies proving this was safe to give to newborns. The U.S. vaccination recommendation process is hopelessly compromised by conflicts of interest with vaccine manufacturers who make huge profits and the American Academy of Pediatrics and the CDC. Conclusion, if, as with the original rotavirus vaccine, which was pulled after a handful of adverse reactions, hepatitis B vaccine was recommended originally without scientific proof that it was safe in a broad sample of racially and genetically diverse babies less than 48 hours old before they established that recommendation, then the CDC has been experimenting on babies like guinea pigs. And this committee should suspend that universal at-birth immunization policy. Thank you.
My heart goes out to you. I hear the pain in your voice, and thank you for your diligence and your well-structured comments. With that, we need to proceed to the public comments period. Again, my apologies for our affiliates that we've not been able to get to all of you. The first, and these are timed, by the way. We have the clock timer, okay. So Miss Kayla, I can't pronounce your last name. Kayla, are you there?
Yes, sorry, I'm here.
Thank you. Please proceed.
Yep. Yes, thank you. Good afternoon. My name is Kayla Bandit, and I am speaking on behalf of the Center for Advancing Health Equity in Rural and Underserved Populations, who is also part of Hepatitis B's Foundation's coalition. For decades, the universal hepatitis B vaccination has been one of the greatest public health successes in this country. Between 1984 and 2050, it is projected to have prevented over 9.5 million acute infections and more than 2.4 million chronic cases in the U.S. alone. Some have suggested that screening could replace universal vaccination, but the data does not support that. Up to 16% of pregnant women in the U.S. still do not receive hepatitis B screening, and even perfect screening cannot prevent infections caused by false negatives, reporting errors, or infections acquired later in pregnancy. Prenatal screening also does nothing to prevent horizontal transmission, which remains a serious threat in daycares, households, and other routine childhood settings that is responsible for half of all infections occurring before age 10 prior to the universal birth dose recommendation. We are already seeing consequences of creating confusion around the safety of this vaccine. States and birthing hospitals are reporting declines in hepatitis B vaccination among newborns and increasing parental concerns about safety, despite no change to the actual evidence. Even some mothers living with hepatitis B are now refusing the birth dose, placing their own infants at the highest risk of infection. Those early trends are deeply troubling and demonstrate how even small shifts in messaging can undermine public confidence. They also represent newborns who may miss critical protection simply because the messages became unclear. We cannot allow uncertainty to put families in this position. When parents are making critical decisions about their family's health, they deserve clear, consistent, and evidence-based guidance. Removing a universal recommendation doesn't expand parental choice. Instead, it limits it by creating barriers to timely vaccination and complicating what should be a straightforward path to protection. This also comes down to preventing liver cancer, one of the deadliest cancers and the only cancer that we can truly prevent at birth. The highest risk infections occur in infancy, and they are entirely preventable with a timely birth dose. But prevention only works when the recommendation is clear. Research has shown that shared clinical decision-making and risk-based approaches simply do not reach every baby vulnerable to infection. Only a strong universal recommendation can do that. Thank you for your time.
And thank you for finishing before the end of your allotted time. Mr. Noah Louis Ferdinand, are you there?
Yes, can you hear me?
Yes, sir.
Hi, this is Noah Louis Ferdinand. I'm the communications coordinator at Voices for Vaccines, a national organization that works to spark peer-to-peer conversations about vaccines and the diseases that they prevent. We're also a program of the Task Force for Global Health. My statements represent Voices for Vaccines, the Coalition for Global Hepatitis Elimination, and the Task Force's position on Hep B birth dose vaccination. The hepatitis B birth dose vaccine is a triumph in public health. Routinely administered in the US since 1991, it has reduced new infections by 99% among children and adolescents. Entire generations have been spared lifelong infections that can lead to cirrhosis, liver failure, and liver cancer. The policy is so effective that eliminating Hep B in the United States is now actually within reach. Reversing this long-established practice would break with more than 3 decades of evidence supporting Hep B vaccination for all newborns. Similarly, moving to a tepid recommendation of shared clinical decision-making would be misguided. Shared decision-making is always the case, but it is ACIP's recommendations based on the best available science that actually guide those decisions. Universal newborn Hep B vaccination is a safety net that ensures all babies receive protection, not just those with perfect paperwork. Infants born to mothers diagnosed with Hep B are at the highest risk for infection, so screening is recommended for all pregnant women. However, about 15% are missed, leaving their Hep B status unknown, and test results are not always available at delivery. Infants can also be exposed to the virus during healthcare and in households. Programs to improve maternal screening will certainly benefit mothers and help ensure infant vaccination, but until those efforts show major improvements, stopping universal newborn Hep B vaccination is premature. Timing matters. Transmission of this virus occurs during delivery. When Hep B virus is transmitted at birth, 85% of infected infants develop lifelong chronic infection. Of those, about 1 in 4 will die from liver cancer or cirrhosis. Once the baby is exposed to the virus, the immune response to the vaccine must begin immediately to get ahead of viral replication and prevent this lifelong infection. Delaying the vaccine even by a day increases the risk of transmission to the newborn. Administering the vaccine as soon as possible after delivery thus provides the strongest protection. With Hep B vaccination, our nation has the real opportunity to eliminate Hep B for future generations. Today, that progress depends on keeping in place a policy that is working as intended. We urge the Secretary of Health and Human Services and ACIP members to rely on the strong scientific evidence and decades of program experience that shaped previous recommendations. Continue to recommend the hepatitis B vaccine for all newborns. By doing so, ACIP will move the United States towards a future in which hepatitis B is no longer a threat to American children and toward the ultimate goal of eliminating hepatitis B for all. Thank you.
Thank you, sir. The brief announcement for our liaisons colleagues. My and our desire is to hear you out to the greatest extent possible. And so the plan is to proceed through this public comment period. Then a brief break. I am a male of a certain age, so appreciate that. And then update on work groups, agency updates, and then as time will allow, to return to your comments before we adjourn. So that's the intention for those of you that wish to stay on so that you might comment later on. With that, I call Mrs. Katrin Werner-Perez as our next public commenter.
Good afternoon. My name is Katrin Werner-Perez, and I serve as the Director of Health Programs at the Alliance for Aging Research. The Alliance was grateful to partner with over 60 mostly non-pediatric organizations representing public health, older adults, patients, family caregivers, consumers, and healthcare workers on a letter emailed to ACIP members earlier this morning to express support for everyone having access to every vaccine that they need, regardless of age. We ask ACIP to consider the following. First, we ask you to preserve clinician and parental choice by maintaining the universal birth dose and schedule for hepatitis B in ACIP's standard and vaccines for children program recommendations. Decades of evidence has consistently shown that universal administration of the hepatitis B vaccine within the first 24 hours of life is the most effective strategy to prevent early childhood infections. Our previous risk-based vaccination strategy failed. Prior to the 1991 change to universal vaccination, nearly 20,000 babies and children were infected annually in the U.S. The risk of long-term complications is extremely high in infants, with up to 90% of babies infected in their first year developing a chronic infection. Let's not forget that infants can also be exposed to hepatitis B after birth by living with or being cared for by someone with an infection. More hepatitis B screening will not stop those cases, but vaccination does. Since the U.S. adopted the universal hepatitis B birth dose recommendation 35 years ago as the standard of care, it has led to a 99% reduction in cases of acute hepatitis B in kids under age 19. Please do not reverse this. Second, we ask ACIP to defer to the broader scientific community regarding the safety of vaccine adjuvants and other ingredients and to refrain from votes on these topics. Adjuvants, including aluminum-based adjuvants, play a critical role in enhancing the immune response to vaccines, particularly for older adults. A comprehensive study in the July issue of the Annals of Internal Medicine among 1.2 million children over 20 years found no association between aluminum exposure from vaccines and the development of 50 chronic conditions, including autism. Aluminum is ubiquitous in many everyday items we consume. Our bodies naturally clear it whether we ingest it or inject it. This is not conjecture, it is science. Addressing safety concerns about vaccine ingredients should rely on scientific evidence. In closing, the vaccine schedule, including its evidence-based timing recommendations, has proven to work over decades of studies. Narrowing or removing recommendations will restrict access and create barriers to patient and provider choice. We urge the committee to maintain the current vaccine schedule. Thank you.
Thank you. We're now at Dr. Vivian Wong. Are you there, Vivian?
Yep. Yes, can you hear me?
Yes, ma'am.
Yes, hi, good afternoon. My name is Dr. Vivian Huang. I am an internist and a public health physician and a patient. As a public health physician, I have worked tirelessly to eliminate vaccine-preventable diseases here in Maricopa County, Arizona, on the Navajo Reservation, in New York City, and globally. While we were desperately fighting Ebola in Sierra Leone a decade ago, we were also dealing with a measles outbreak as West Africa's public health system collapsed in the face of Ebola. In Syria, while working with Doctors Without Borders, and as the war raged, the medical system crumbled. I had the privilege and responsibility to vaccinate thousands of Syrian children against vaccine-preventable diseases. And most recently, I served in New York City during the COVID pandemic. I am proud to have led some of the first COVID vaccination campaigns in New York City's Manhattan Chinatown. Today, I want to share with you why public health and vaccines matter to me. It comes from a place of personal experience and pain. Born and raised in the US, I never benefited from the birth dose Hep B vaccination program. I was born before it was implemented universally in 1991. I was exposed to hepatitis B at the age of 19 and found out when I was donating blood at my college. That experience is one of the main reasons I went to medical school. I didn't want what happened to me happen to others. Since then, I have naturally cleared the infection and considered immune. However, there is a rare chance the virus could reactivate later. And I can never donate blood again or participate in clinical studies, which deeply pains me to not be able to serve others. I think, had I been given the chance of getting the birth dose, it would have prevented my infection and a lifetime of worry of getting sick. I live with this reality every day. The birth dose Hep B program has been a true public health success in the US. We rarely see it in our younger generations and have nearly eliminated this disease in 35 years. And perhaps we are a victim of our own success, but we cannot allow this preventable disease to come back and destroy the lives of our healthy babies and children. Let us not go back to the era when our babies and children are infected with hepatitis B. Let them not be a casualty like I have been. My strong plea here today as a public health physician and community leader is to ask that you review the data presented and the successes gained from the birth dose recommendation and make the right decision to continue with this recommendation. We are so much closer to eliminating hepatitis B in the US. Let us not reverse all the good work that has been done. We cannot afford to delay the birth dose. Our future generations are depending on us to keep them healthy and safe. We have the tools to keep them safe, so why would we take these tools away? Let us do them right and do not disappoint them. Thank you for listening, and thank you for your time today.
Thank you, Dr. Wong. Dr. Allison Grady.
Good afternoon. My name is Dr. Allison Grady, and I'm an oncology pediatric nurse practitioner at a leading children's hospital and a clinical assistant professor of nursing. For 23 consecutive years, nurses have been recognized as the most trusted profession in America. I am a member of the National Association of Pediatric Nurse Practitioners, but I am here today as an individual and pediatric expert to strongly urge the committee to maintain the integrity of the long-established vaccine schedule. Discussion about changing the number of doses, the formulation of the vaccines, and the schedule in which they are received is extremely worrisome to clinicians, especially us in pediatric cancer care. Adjuvants and vaccines boost the immune response to antigens like hepatitis B virus. This is help my young patients with cancer desperately need. The science is clear. Current guidelines have long been vetted by scientists in vaccinology. Timely immunization safely protects children from the scourge of vaccine-preventable diseases. Some in our community, and perhaps some on this committee, believe vaccines should be a family's choice. However, those individual choices deeply affect the most vulnerable individuals in our communities, like my patients who are immunocompromised. Children with cancer are given high doses of chemicals that destroy their cancer, but also ravage their immune system. They depend on herd immunity to be protected from viruses and bacteria like Hib, which one of my patients had to fight in addition to their cancer. These are serious, deadly situations. In Wisconsin, we have seen rates of immunization steadily decline to less than 90% of kindergartners being fully vaccinated. This means my cancer patients are less likely to be able to attend school or to be out in public, and their parents and siblings are less likely to be able to participate in day-to-day life because of the potential harm to their loved ones. These preventable diseases, which haunt my patients, also rob otherwise healthy children of the joys of childhood, which are school, play, and friendship. On behalf of the hundreds of thousands of nurse practitioners and nurses caring for our nation's children and families, I urge this committee to not waste valuable time and resources trying to disprove the safety and efficacy data that has come from decades of rigorous scientific research and on which all leading medical and scientific organizations agree. I strongly encourage the committee to protect the health of those who are too young to protect themselves. Maintain the current evidence-based schedule and send an unequivocal message to parents who are seeking to do the right thing for their child, family, and community. Vaccinate. We trust the science, we value the health and well-being of children, and we believe that the children deserve a future without vaccine-preventable illness. Thank you very much.
Thank you. Mrs. Chloe Humbert.
Hello, yes.
Chloe, are you there?
Can you hear me?
Yes, proceed.
Thank you. Hi, I'm Chloe Humber. Dr. Dimitri Daskalakis said in an interview recently that the idea of testing out of the birth dose of the hepatitis B vaccine ignores the fact that a significant amount of babies get infected from people in their household other than mom. And when it's transmitted, I read that hepatitis B is up to 100 times more contagious than HIV. Dr. Dimitri warned that public health contrarians, my words, not his, he said that some people might claim hepatitis B doesn't happen to quote-unquote normal families. I certainly hope he was wrong about that, but I'm so appalled and embarrassed for anyone who would say stuff like that. Over 20 years ago, I did photography at a local AIDS awareness walk in Pennsylvania. It was a memorial for someone who is then described as quote-unquote a normal boy. He was transformed into a courageous young AIDS activist in the 1990s after getting HIV from a blood transfusion. His name was Christopher Robinson, and he died 25 years ago, the same week as my father, actually. But Christopher was just 18 years old. None of us are safe until we're all safe. Vaccines are public health. They're for all of us, broadly, universally, including babies. There's not a vaccine for HIV, but there are vaccines for a lot of threats to public safety. And vaccines have been allowing so many of us who might not have otherwise to pursue life, liberty, and happiness, and for longer. And I don't want that to stop. Certainly not because a few people are fearful and misinformed or have grossly bigoted opinions. We, the taxpayers, pay for the health agencies to protect the public with modern medicine, including interventions like vaccines. We're not paying for y'all to play games based on eugenics, which is a pseudoscience, and also immoral and deranged in any case. Dr. Dimitri Daskalakis also mentioned in that interview that the Insurance Association is disregarding the ACIP recommendations now because they don't trust the committee. The insurance industry is notoriously careful about avoiding financially risky and bad information, so that's notable. I've been unhappy with the CDC for over 20 years, and yet my estimation of this institution couldn't be lower. But we still have free speech rights in this country, so I'm going to go on the record. I've been thinking that maybe this is really the natural expected endpoint of an agency that has for decades operated public health based on business interests like the cattle industry and commercial airlines. Thank you.
Thank you. Cerise Murata.
Hello. I am sharing my comments today as a bereaved mother, scientist, and advocate. I want to first state that regarding this week's topics of the hepatitis B vaccine, the childhood immunization schedule, and vaccine adjuvants, numerous scientific studies and decades of investigation reassure us that routinely recommended vaccines for children in the U.S. are safe and remain one of the best tools we have to prevent dangerous diseases. I am genuinely curious why there is so much chaos and confusion in the immunization space right now. We all care about the safety of our children, our families, and our communities. But when I looked at this week's ACIP agenda, I could not help but wonder why ACIP is rehashing settled science with no new safety signals indicating necessity. Why are there no discussions of current outbreaks of measles and pertussis? Why are we not discussing flu, since we just had a record-breaking season for pediatric flu deaths? ACIP should be discussing these outbreaks, which are occurring because of declining vaccination rates. I lost my healthy 5-year-old son Joseph to flu in 2009. Over 2,700 children, specifically 2,745 children, have died from influenza since reporting began in 2004. Recent news indicates FDA may be planning to alter the vaccine approval process, which could affect the availability of flu vaccines as well as other vaccines. This new development seems to indicate that FDA and ACIP are not aligned with the scientific community. Why is that? When this administration makes statements about transparency and gold standard science, it seems that their actions do not reflect these standards. Let's be clear. This chaos and confusion is not making America healthy again. It's making individuals and parents second-guess their choices about getting vaccinated, which will lead to more preventable deaths and grief-stricken families and communities. This administration is not empowering people to make informed choices. It's taking away their right to choose by making it more and more difficult to access vaccines. There is no acceptable loss when it comes to a child. It was incredibly devastating to watch my son Joseph die in front of me in the ICU. Actions by this committee that create access barriers to vaccines will lead to more parents having a story like mine. We know from history what will happen if vaccines are not available. So I ask the committee, are you prepared to make decisions that will cost children their lives? Because that's what's at stake here. And you will have to answer to thousands of American families when that happens. The science is clear, vaccines save lives. Without them, our families and communities are at risk. Thank you.
Thank you. Dr. Rita Kuwahara.
Can you hear me?
Yes, ma'am.
Thanks for the opportunity to speak today. My name is Dr. Rita Kawahara, and I'm a primary care internal medicine physician and senior advisor for medicine and health policy at the Association of Asian Pacific Community Health Organizations, representing community health centers. Today, I would like to talk about the importance of maintaining universal birth dose hepatitis B vaccine recommendations. The hepatitis B vaccine was the first anti-cancer vaccine developed, and the birth dose hepatitis B vaccine saves lives. Prior to universal childhood hepatitis B vaccination in the U.S., 18,000 children were infected with hepatitis B annually before age 10. Nearly half were infected at birth, and many of the other half had no known virus exposure. Now, this number is down to nearly zero, and 90,000 deaths have been prevented since 1991. We also have 40 years of safety data for the hepatitis B vaccine, and scientific evidence has shown the hepatitis B vaccine given at birth is safe and highly effective at preventing hepatitis B in newborns. Protecting newborns from hepatitis B at birth is critical because 90% of newborns infected with hepatitis B will develop chronic hepatitis B, and 1 in 4 of those with chronic hepatitis B will develop liver cancer, liver failure, or cirrhosis, reducing life expectancy. Providing the birth dose hepatitis B vaccine also allows babies to become fully vaccinated during early infancy once they complete their vaccine series to prevent horizontal transmission of hepatitis B. As a physician, I would like to also emphasize the importance of having universal recommendations for birth dose hepatitis B vaccination to give parents the choice to vaccinate their newborn without unnecessary administrative burdens. A universal vaccine recommendation never forces a parent to vaccinate their child, but it does give all parents the choice to vaccinate their child after considering all benefits and risks. Eliminating universal hepatitis B birth dose vaccination means that parents will no longer have the freedom to choose whether to vaccinate their child. It also means that newborns at highest risk of hepatitis B infection at birth, including babies born from mothers with hepatitis B or unknown hepatitis B status, may no longer have access to the vaccine if hospitals stop stocking the hepatitis B vaccine, or clinicians must remember who to offer the vaccine and complete all administrative tasks to prove medical necessity before providing the birth dose vaccine. It is also unrealistic for hospitals and birthing centers to test mothers in active labor for hepatitis B and expect to receive immediate results to determine which newborns promptly need the hepatitis B vaccine. With fewer women on Medicaid or able to afford health insurance and closure of hospitals and many labor and delivery units in rural communities, fewer women will have access to prenatal care, and more will have to travel farther and present to hospitals at later stages of labor, increasing the number of pregnant women never screened for hepatitis B, making universal birth dose hepatitis B vaccine recommendations even more important. Further, the Vaccine Integrity Project and CIDRAP just released a report after public comments closed, finding no benefits to delaying the birth dose, but rather critical risks with changing current recommendations. As a physician, I urge the committee to maintain universal birth dose hepatitis B vaccine recommendations to give all parents the choice to vaccinate their newborns and save lives with a safe and highly effective anti-cancer vaccine. Thank you.
And thank you for your comments. Finally, Dr. Toby Rogers.
Good afternoon. Can you hear me?
Yes, sir.
Excellent. Thank you for the opportunity to speak. My name is Toby Rogers. I have a PhD in political economy from the University of Sydney and a Master of Public Policy degree from UC Berkeley. I'm currently a fellow at the Brownstone Institute, where I write about corruption in the pharmaceutical industry. Using documents obtained via the Freedom of Information Act, the Informed Consent Action Network demonstrated that the two most widely used hepatitis B vaccines in the country, Recombavax and Engerix, never should have been licensed by the FDA in the first place. The clinical trials for Recombavax and Engerix did not include a saline placebo control group, were too small to detect uncommon adverse events, and were too short to detect the majority of harms. On that basis alone, gold standard science requires that they be removed from the market. The autism rate in this country has skyrocketed since the introduction of hepatitis B vaccines, from 1 in 5,000 children diagnosed with autism in the 1980s prior to the introduction of hepatitis B vaccines to 1 in 31 children on the autism spectrum today. A study by Thomas Verstraeten at the CDC's Epidemic Intelligence Service in 1999 showed that the birth dose of the hepatitis B vaccine increased the relative risk of autism more than 11-fold. Soon thereafter, Dr. Verstraeten went to work for GSK in Belgium, and the CDC has been covering up his initial research findings ever since. Vaccinated versus unvaccinated studies by Gallagher and Goodman, published in 2008 and 2010, also show that hepatitis B vaccines significantly increase autism risk. Hepatitis B vaccines have killed an astonishing number of children in the U.S. over the last 35 years. The Vaccine Adverse Event Reporting System contains 643 reports of death of children and 52,281 total reports of harm in the U.S. across all ages in connection with Recombavax and Engerix shots. Hepatitis B is also a component in many combination vaccines, including Pediarix and Vaxelis. The Vaccine Adverse Event Reporting System contains 1,348 reports of deaths of children and 82,980 total reports of harm in the U.S. across all ages following combination hepatitis B vaccines. Remember that VAERS reports are a significant undercount of harms. Respectfully, the proposed ACIP voting questions do not go far enough to address documented safety problems. Moving the birth dose of hepatitis B vaccine to 2 months would only produce a small reduction in autism and SIDS rates. Combination shots are not safer. Moving the recommendation to age 12 would be better, but would increase autoimmune disorders and POTS cases in teenagers because of the high aluminum content in these shots. The fact remains that there are no data proving the safety and efficacy of the hepatitis B vaccines on day 1, 2 months, or 12 years of age. Given that, I believe that hepatitis B vaccines should be removed altogether from the CDC childhood schedule. Thank you.
Thank you very much, Dr. Rogers. And finally, Joanna Colburn.
Good afternoon. Thank you for the opportunity to comment. I'm Joanna Colburn. I'm speaking on behalf of the National Foundation for Infectious Diseases, also known as NFID. Our mission is to educate and engage with the communities, public, and healthcare professionals about infectious diseases across the lifespan. As ACIP considers several important issues this week, including vaccine safety and the childhood and adolescent immunization schedule, NFID urges the committee to rely on rigorous evidence-based science to guide all immunization policy decisions. Given the importance of the upcoming vote, I'll focus my comments on the hepatitis B vaccination for infants. Hep B is a serious liver infection that can lead to cirrhosis, liver cancer, and even death. The birth dose of hepatitis B vaccine has been the standard of care in the U.S. since 1991, and it has played a major role in reducing hepatitis B infections nationwide, but risks do remain. Up to half of U.S. adults with chronic Hep B infections don't know they're infected, and infants who acquire the infection around the time of birth face the highest risk of lifelong infection and its most severe complications, including liver cancer. We cannot lose sight of this fact. The hepatitis B birth dose is one of the strongest tools we have to prevent infection, protect infants, and break the cycle of transmission. Decades of evidence show no safety, efficacy, or long-term benefit to delaying the birth dose. In fact, delaying the birth dose until 2 months of age could result in more than 1,400 additional infections and over 480 deaths per birth year. Since 1991, the birth dose has contributed to a 99% reduction in pediatric hepatitis B infections. For these reasons, NFID strongly supports maintaining the current hepatitis B vaccination schedule, including the birth dose and broad adult vaccination. I also want to reaffirm NFID's support for the rigorous ACIP process itself. The strength of ACIP recommendations depends on the expertise of its work groups. We implore you to reestablish work groups that previously used a rigorous evidence-based evaluation method with input from experienced CDC staff, independent scientists, clinicians, and liaison organizations. Their careful review of disease burden and scientific evidence helps ensure that U.S. vaccine policy remains grounded in the best available science and promotes optimal patient care. Finally, a brief word about the childhood and adolescent immunization schedule. These schedules are built on decades of robust data and have dramatically reduced diseases including measles, pertussis, and other once common infections. But recent declines in vaccination have led to outbreaks, including the highest number of measles cases since the disease was eliminated in the U.S. and a 6-fold increase in pertussis cases in 2024 compared to 2023. Weakening the schedule now would put more children at risk. NFID supports science, not opinion. We will continue to support recommendations that protect those most at risk and advance health equity. By maintaining rigorous science-based guidance, ACIP can play a critical role in safeguarding the nation's progress against vaccine-preventable diseases. Thank you for your time.
Thank you. A brief comment from member Dr. Evelyn Griffin.
Thank you. Thank you for all the contributors, and we are heartfully sorry for any harms anyone had or losses that y'all expressed, and appreciate your bravery for coming forward with them. And we are here to first do no harm. This is what we are tasked with, is to assess the calculus of risk versus benefit for everyone. That's informed consent with each of our patients. And any harm is tragic, of course, from infection of hepatitis B and chronic disease with it, or death from it, as is injury from vaccine. So if with a universal birth dose, the calculus is altered by exposing everyone to potential risk, including, taking babies who are of low risk and exposing all of them. And we have to be cognizant of the fact that the past several decades have seen an explosion in chronic disease, especially the highest rate in our children. Something is happening, and we have to address that. We cannot just blindly keep saying, I'm not saying it is vaccines that is causing this, but vaccines is what we are tasked to explore, so we have to investigate these topics. So I appreciate the speakers for bringing up the topics of adjuvants and aluminum. As I mentioned earlier, macrophagic myofasciitis has found aluminum in injection sites, same type of aluminum compound that is in adjuvants of recipients of vaccines. So it's a very close correlation. Is that causal to the person's autoimmune condition? That is, of course, like we discussed earlier, has to be studied further. There are other conditions that are autoimmune conditions that have been characterized, autoimmune inflammatory syndrome that was associated with adjuvants, neuroinflammatory changes that were demonstrated, neurotoxicity changes with aluminum that was found. So both products that are Engerix and Recombivax has aluminum adjuvant. And the question is, this is part of the product that is being given within the first few hours of life at a time when babies' blood-brain barrier is immature, their detoxification systems are immature, as is their kidney for excretion. So it is very concerning when scientists have done post-mortem studies on brains of patients, neurologic patients, who where it has been found to have aluminum in their brain. There's no biological use for us to have aluminum in our body, and so the clear association with aluminum neurologic changes, yes, it can be coming from the environment, but it does beg the question, should we be injecting it into ourselves from day one of life when we are turning around and staring down a unknown cause of rapid acceleration of epidemiology, of pathology in our children. So it warrants caution, if nothing else. First, we should do no harm.
Okay, with that, we're going to be taking up adjuvants tomorrow, time permitting, among other things. I think right now we're anticipating a brief break for those of us that have been tied to our chairs, and we will reconvene at 5 minutes from now. It's a little bit after 3:30 for an update on work groups, then agency updates. That's a kind of a round table. And then to the extent that is feasible, we are going to return to discussions with liaisons. So with that, brief break for those of us that need it.
Yes.
Can we take our seats, please? Recognizing that we're pushing our schedule, and we're committed to the extent possible in providing an opportunity for our liaisons to continue to share their point of view. So the next item on the agenda is an update on work groups. The work groups are the place where the business really happens within the Advisory Committee on Immunization Practices. There, I have heard, and we have all heard many commentaries, and some of them quite strongly worded, concerning the process within the Advisory Committee on Immunization Practices for doing discovery, diligence, and investigations. All of that, according to the Federal Advisory Committee Act Charter, transpires within the work groups. The work groups have to be formally chartered and designated, and the ability to share information from those work groups with the general public has constraints that come to us from congressional language. It's not something that the CDC has invented. I can share from me personally, I was not aware this was the case. I've been attending ACIP meetings for a couple of decades, and I was always at a loss about why the work groups were largely confidential. But this flows from the charter under which ACIP operates, coming from the Congressional Federal Advisory Committee Act. So that's my preamble to the work groups. The work groups matter. And in terms of an update on the work groups right now on the agenda, the work groups that have been chartered under this ACIP have developed several terms of reference documents that have been updated under the new working group chair leadership. These are referred to as terms of reference. Some of us might prefer the term scope of work to describe what the charter is for these work groups, but terms of reference is the formally approved language. These updated terms of reference will be posted to the ACIP website soon, and they include the TORs for influenza, respiratory syncytial virus, and human papillomavirus. So for those of you that are closely following the activities of the Advisory Committee on Immunization Practices, I recommend that you follow the ACIP website and look for those modified and updated terms of reference in those topic areas. CDC leadership and ACIP are also initiating a work group which has not yet been chartered, having to do with vaccination and pregnancy. So you can look forward to the terms of reference emerging regarding that. But these terms of reference, I can tell you from personal experience, are not a trivial undertaking. They have to be vetted legally. They're vetted through the CDC, Permanent Employee Corps, and through the upper levels of the management of the Department of Health and Human Services under Secretary Kennedy. So that's my update on the work groups, and I'm now turning to agency updates, beginning with the Centers for Disease Control and Prevention. Are there updates from the CDC that you wish to share?
Hi, yes. Can you hear me, Dr. Malone?
Yes, ma'am.
Okay. Good afternoon, everyone. My name is Dr. Renata Ellington. I'm the acting director for the CDC's National Center for HIV, Viral Hepatitis, STD, and TB Prevention, also known as NCHHSTP. Since 2023, NCHHSTP has responded to 13 FDA requests. And today I want to provide an update on an ongoing outbreak of HIV and hepatitis C in Penobscot County, Maine. This is the area that includes Bangor. Penobscot County typically has an average of 2 new HIV diagnoses per year. However, in 2024, there were 14 diagnoses associated with injection drug use. The outbreak continued into this year, into 2025, at an increased pace with an additional 12 new diagnoses in the first half of 2025. As of October, a total of 30 people have been newly diagnosed with HIV, nearly all of whom are also co-infected with hepatitis C. The Maine Centers for Disease Control, which I'll refer to as CDC Maine, is leading efforts to assess and respond to these increases. CDC, we are supporting the health department's outbreak response efforts and we provided initial on-the-ground technical assistance in August of 2025. Following that, we continued conducting ongoing virtual assistance. And earlier this week, we have a team of HIV and viral hepatitis SMEs who returned to Maine to actually conduct the FEA. The initial on-site technical assistance occurred in August, as I indicated. For this first visit, there were 5 CDC staff who were deployed, and these staff provided capacity building assistance to CDC Maine staff focused on strengthening and sustaining outbreak response activities, including modernizing surveillance data and expanding access to testing, prevention, and treatment services. Upon returning to Atlanta, CDC continued to assist by providing virtual support. This support included several things, including developing the data collection protocol and tools, drafting the educational materials and the materials for community partners. We also held ongoing calls with CDC Maine and the local community-based organizations to obtain feedback on the proposed FEA strategy and the data collection tools that would be used. And we worked on completing preparations for the qualitative assessment to be conducted as a part of FEA. As of December 1st, this week, we have a team of 6 CDC staff on the ground in Bangor, Maine, to conduct an FEA. The staff will remain on site in Maine until December 19th. While in Maine, they are working with the health department to actually conduct the interviews with people affected by the outbreak to understand the barriers to and the facilitators to access HIV and hepatitis C testing, treatment, and prevention. They're also working with the staff on the ground to assess knowledge of risk factors and to also get a better understanding of the practices that may be contributing to the transmission. All of this information together will be able to help develop the educational resources for the providers, the response partners, as well as the community members. It's extremely important to understand the causes of these infectious disease increases, effectively addressing them with the providers and the patients, and also working toward preventing future infections and this is a flagship programming of NCHH, STP, and CDC to protect the health and the safety of all Americans. Thank you for your time. Over.
And thank you, ma'am, for your efforts and rapid response and clear competence. Appreciate that report. Now we have another report from CDC leadership or members. Please
Hi,
proceed.
thank you. Can you hear me?
Correct. Yes.
Great. Hello, and thanks for the opportunity to present to you all this afternoon. My name is Brandy Limbago. I'm the acting director for the National Center for Immunization and Respiratory Diseases. I'm going to give you some updates today on measles, avian influenza, and respiratory virus season. So as of December 2nd of this year, 1,828 measles cases have been reported to CDC from 43 U.S. jurisdictions. These are from 46 different outbreaks, and 87% of the confirmed cases are outbreak associated. For comparison, 16 outbreaks were reported during 2024, and only 69% of cases were outbreak associated in that year. Among all of the cases reported this year, 92% are unvaccinated or have an unknown vaccination status. There have been 3 confirmed deaths this year from measles, including 2 among children. And despite this, though, the overall risk to the U.S. population is low, given current measles vaccination rates and coverage. Switching now to H5, since the beginning of the current avian influenza outbreak in April of 2024, there have been 71 confirmed cases of human H5 influenza infection in the United States. Most of these have been caused by H5N1, largely associated with cattle and have generally had clinically mild illness. But the most recent case of H5 infection that occurred in November was in a Washington state individual due to an influenza A H5N5 virus. This is the first known infection with this H5N5 virus in a human. So it turns out in this case, this was an older person with underlying conditions, and this infection was unfortunately fatal. And this is the second death this year due to an H5 avian influenza infection. Again, as with measles, the general risk to the population from H5 bird flu remains low. However, there is greater risk to those people who work directly with infected animals for H5 infection. And it's important to also note that no human-to-human transmission of H5 has been identified. CDC does continue to closely monitor for H5 infections among humans in the United States using multiple influenza surveillance systems. And then finally, an update on respiratory virus season. As of December 1st, 2025, the amount of acute respiratory illness in the US causing people to seek healthcare remains at a low level. RSV, respiratory syncytial virus activity, is increasing in the southeastern and southern areas of the country, with emergency department visits increasing among children 0 to 4 years of age. COVID-19 activity remains low nationally, and seasonal influenza activity also remains low nationally, but is increasing, especially among children and young adults. Finally, I would like to just mention that it is not too late to be vaccinated against influenza, COVID-19, and RSV based on your individual eligibility for these vaccines. Thanks.
Follow-up question. Did I understand correctly that we have a little issue with a mismatch H3N2 that's not included in the current formulation? Over.
We do know that the current H3N2 virus is drifted somewhat from the strain that is included in the vaccine for this year. That said, the influenza vaccine does still provide, protection against the other strains included in the vaccine and against the most severe influenza infection. And we are continuing to monitor the vaccine efficacy of this vaccine against the H3N2 subclade K. It's just too early to tell because the activity so far has been so low that we cannot do those vaccine effectiveness studies at this point.
Thank you very much. Now we have a third presentation from CDC staff. Is that true?
Yes. My name is Chris Braden. I'm the acting director for the National Center for Emerging and Zoonotic Infectious Diseases, or NCEZID. We have expertise in over 800 different pathogens, including bacteria, parasites, viruses, fungi, and even prions. During the last ACIP meeting, I provided an update on an outbreak of Ebola in the Democratic Republic of Congo. As many of you are aware, outbreaks of viral hemorrhagic fever viruses can be explosive, deadly, and costly, as exemplified by the multinational outbreak of Ebola in West Africa in 2014 through 2016. Through a concerted effort at CDC to support the Ministry of Health, the Ebola outbreak in DRC has been controlled, and the outbreak was declared over on November 30th, with 64 cases and 45 deaths. We are now supporting a 90-day enhanced surveillance period and an Ebola survivor program to monitor possible persistent asymptomatic infections. Unfortunately, there is a new outbreak of another viral hemorrhagic fever, Marburg disease, in Ethiopia, which was reported by the Ethiopian Ministry of Health on November 14th. As of December 2nd, there have been 13 confirmed cases, including 8 deaths. CDC staff from headquarters and CDC's Ethiopia country office are supporting Ethiopia's efforts to respond to their first outbreak of Marburg. CDC deployers are supporting epidemiology and laboratory activities in the outbreak area, as well as response coordination and providing guidance on border health measures. The risk of this outbreak poses to the U.S. is low, and CDC is ready if viral hemorrhagic fevers like Marburg were to reach the U.S. On the domestic side, CDC is partnering with state public health officials, the California Department of Public Health Infant Botulism Treatment and Prevention Program, and the U.S. Food and Drug Administration to investigate a multi-state outbreak of infant botulism linked to infant formula. This is the first outbreak of infant botulism due to contaminated commercial infant formula reported to CDC. Infant botulism happens when a baby swallows Clostridium botulinum spores that grow in the gut and produce toxin. Infant botulism starts with constipation, but is usually first noticed as difficulty feeding, a weak and altered cry, and lack of head control. As of November 26, CDC and its partners have now identified 37 cases, all hospitalized, across 17 states. There have been no deaths to date. CDC's investigative team is working to collect additional information for infant botulism cases reported before August 2025, when the current outbreak was first identified. The most up-to-date information of this ongoing investigation is available on our website. That concludes my update. Thank you.
Thank you very much. Follow-up question regarding the Ebola outbreak. Are we still seeing good match between the recently licensed vaccine strains and the circulating Ebola virus, or are we having drift issues or other mismatch issues? Over.
Yeah, and this is a good question, and one something that we continuously monitor for, and there has not been a mismatch to date. You may also know that there's an investigative vaccine for the Marburg virus, and we are looking for the same thing, but also have not seen any mismatch to the vaccine for Marburg.
You're referring to the, I think it's the Serum Institute adenovector product, right, which is still, as you correctly point out, experimental. Thank you very much.
Robert, can I ask a question?
Please, Cody.
Yes. Thanks. It's a little hard being remote. I have a question for Dr. Limbago. On her, I believe you said there has been no person-to-person transmission of H5, and I think you're referring to the United States. Is that correct? Because there has been transmission elsewhere in the world. Am I correct?
Yes, I was. My entire presentation was in reference to the situation in the U.S.
Thank you.
Cody, are you good now?
Yes, sir.
Thank you, sir. So next we will hear from our colleagues at CMS in the land of Dr. Oz.
So he told me that he didn't have any updates.
No updates. Okay. But we've benefited from his advice and counsel a couple times already. And there's not much happening at the Food and Drug Administration, is there? You wish to share any recent events?
Nothing dramatic or salacious or anything has been happening at the FDA. No, it's just some minor things from CBER. I don't know. They're not minor related to vaccines. So we are revising our framework for safety surveillance of vaccines right now in CBER, so that we will be able to, so that we're going to be looking for more potential safety issues with vaccines. So basically widening the net of potential outcomes that we're looking at, and looking at different methodologies. So we're less likely to miss potential safety issues with vaccines. So that's in the works right now, and actually currently we're already starting to use some different methodologies than we've used in the past, so that's exciting. And then there was a memo that many people know about that described COVID-19 vaccine deaths that did appear to be linked to the vaccine that were reported to VAERS. There was a full investigation that was done, 4 years ago, 4 years ago, a number of years ago, that wasn't, the results of which were not reported to the public. And so now it seems like some of those are going to be, sounds like they're going to be released to the public. the latest memo and look at these data were done by CBER staff, and so that should be coming imminently soon. More information on that. And it does highlight, the need to be more, so that we actually use the information that we're gathering so that we're more transparent to the public with things like the VERIS database when we have information, and explain sort of how we're using it and our, sense of the likelihood that deaths or injuries may be due to the vaccine or any vaccine and what we're seeing. And then there are going to be some changes that have been outlined to require better evidence for expanding indications of vaccines to populations such as pregnant women, younger children. So when you have an already approved vaccine, but you want to expand the population, an indication that it will also be requiring randomized control trial data so that we're more certain about the safety of these products and the different populations that they're used in. So I think I'll end with that.
Thank you, Dr. Hogue. I'm inferring that some of the more advanced, recently developed data analysis tools and capabilities are now going to be applied to the various existing databases, such as my old colleagues at the Office of the Commissioner and Chief Scientist had advocated a few years ago, is what I'm hearing. Are we here at ACIP focusing on ourselves? Are we, is it, in your opinion, is there going to be a need to consider how these policy changes will be impacting on our obligation to periodically reevaluate positions on existing products? I'm trying to ask the question, do we need to, is it the advice from our valued liaison at FDA that there's merit to ACIP focusing on the potential impact of some of these policy changes? Over.
Well, I mean, I think it would be good for the ACIP members to, be aware of what's happening with the FDA, and it may result in more frequent label changes and updates. And I would just say, hopefully the level of evidence that we're going to be generating in terms of both safety and efficacy will be better and more informative. And so I'm not exactly sure how it would, affect the ACIP, other than to say it may lead to more rapid changes in recommendations, coming from ACIP and CDC.
Okay, so what I hear from that is that we should stay tuned and look and watch for specific modifications in current and future recommendations, but there's no reason for us to act proactively in any way to do threat assessment or mitigation as it relates to these changes. And if you'll permit me one small follow-up. The proposed changes, I infer, are likely to require modifications of the guidance to industry. Is that true? And if so, what kind of timeline might we expect for that?
So yeah, that would be true. That would typically involve guidance to the industry. And I guess I don't necessarily want to speak on timeline if I'm not certain exactly what the timeline would be.
So to be determined. Look forward to future briefings. Yeah. You'll bring us up to speed on that. Is that fair?
Yes. And one more thought while I have the microphone. I just want to say that in relation to the reports in the VERIS database, and that I appreciate the fact that Retsef Levy gave the talk at the last meeting showing that deaths attributed to the COVID vaccine have been already acknowledged in multiple countries, in multiple peer-reviewed studies where it felt it was highly likely due to the vaccine or autopsy, suggested with high certainty that it was. So it wasn't that it was it wasn't that it was unexpected that there would be deaths that are likely attributable to the COVID vaccine in the VAERS database. It was more a question of, when the information would come out. So I just wanted to make that clear.
Roger that. So now we turn to HRSA.
This is Reed Grimes with the Health Resources and Services Administration. No updates to share at this time. Thank you.
Thank you, sir. IHS.
Good afternoon. I'm Dr. Matthew Clark, representing IHS. The Indian Health Service continues to work closely with our federal, tribal, and urban Indian organization partners to mitigate the risk of vaccine-preventable illness in our vulnerable service population. IHS remains committed to raising health status and improving health outcomes in American Indian and Alaska Native tribal communities across a wide spectrum, from the promotion of healthy lifestyles to screening and prevention, supporting traditional culture and healing, and effective management of both acute and chronic diseases. As a comprehensive healthcare system for over 2 million American Indian and Alaska Native beneficiaries, vaccination is a key component to this broader strategy. We're working to advance this strategy across the age spectrum through proactive education, access, and respect for patient, family, and community values and priorities. Tribal communities face many unique challenges that impact access to effective preventive, clinical, and public health interventions. IHS seeks to collaborate with our tribal and tribal health partners to identify vaccine prevention priorities and to promote immunization best practices that meet the current needs in Indian country. Thank you, Mr. Chair, and I'll turn it back over to you.
Thank you very much. Follow-up question. Can you comment on availability of hepatitis B hepatitis B surface antigen testing in Indian health communities, since that's such a topic right now in today's meeting?
So testing is widely available, but I will admit that the turnaround time for results is limited, given the rural and remote location for many of our sites.
So I'm hearing that turnaround time may be days in many cases. Is that accurate?
It may be for our ambulatory care sites, not for our hospital sites.
So the hospital sites, am I understanding from that comment that at the hospital sites, you're likely to have near real-time testing available for expectant mothers?
Yes.
That's super news. Thank you for sharing that intelligence. The next is our colleagues at the National Institutes of Health. Do we have an NIH representative? I know he was on earlier today that can speak to us now.
Can you hear me?
Dr. Kurilla, I'm
yes.
glad to hear from you. Thank you. Please proceed.
Okay, sorry. Yes, no relevant updates from NIH at this time.
Thank you, sir. So with that, we have concluded agency updates. We've concluded updates on work groups, and we are now going to reopen discussion with our liaison members. Is that fair? We had originally scheduled for adjournment at 3:45. Do you have any thoughts representing the CDC on how late we shall go today?
Robert, can I ask a question again? I'm sorry.
Oh, Cody, of course.
Yes. If Matthew Clark is still there, can you comment on the uptake of the monoclonal antibodies for RSV, clesrovimab, and nirsevimab for newborns in the Indian and Alaska areas?
Yes, sir. Dr. Meisner, I appreciate the question. So IHS has taken a very proactive approach to promoting monoclonal antibody immunization in our extremely vulnerable service population. As you know, the ACIP has recommended monoclonal antibodies for RSV not only in the first season for newborn infants, but also universally among American Indian Alaska Native children up to 19 months of age in their second season. This is, as with all things Indian country, there are challenges when it comes to the logistics of administering vaccines out in rural and remote locations. But you are probably aware of the fact that YKHC, Yukon-Kuskokwim Health Corporation, in the first season reported not only an effective vaccination strategy where literally they flew bush plane flights out to remote village locations on the YK Delta, but also a tremendous amount of vaccine or immunization effectiveness in preventing hospitalization in what is considered to be, if not the highest risk location in the world, at least the second highest risk location in the world for serious RSV disease. The overall implementation of RSV immunizations in Indian country varies by location, but I can tell you that working with our CDC colleagues, we've taken a very proactive approach to messaging. And generally speaking, we've had a good response from tribal communities.
And there are adequate supplies?
Yes, sir. So you may be aware that in the first season, especially and to some extent in the second season, there were limitations to the availability of nirsevimab. Incidentally, IHS has taken the position of promoting nirsevimab over clesrovimab because of the real-world efficacy data in tribal communities such as the one that I just referenced. But all American Indian and Alaska Native children up to their 19th birthday are eligible for vaccines for children. And we've been working very proactively with the VFC program and with our CDC partners to ensure access to all of the ACIP recommended vaccines and immunizations in Indian country.
That's wonderful news. Thank you.
Yes, sir.
Cody, you good?
Yes, sir.
Okay. So the advice from our CDC liaison is that we provide an additional half an hour for our liaison colleagues to share their perspectives on the current topics at hand, beginning with Flor Munoz. Flor, are you there still? She talked already? Okay, so Amy Middleman. Amy, are you there?
Hi, thanks so much.
Yeah, thank you.
Yep, I'm here. Thanks so much. Can you hear me?
Yes, ma'am.
Oh, good. Okay. So I want to just make two quick comments. The first one sort of leads into the second one, but I just want to make sure there have been a couple of people who have been noting that the vaccination, after the universal vaccinations for, I'm just trying to find the, give me 1 second, I'm just trying to find the graph that was being discussed. But there was a graph shown, and a couple of people have mentioned that after the universal birth dose, they've mentioned that the fact that in later adolescence and young adults, the fact that the rates have gone down somehow takes away from the efficacy of the universal birth dose. But this is where sort of historical vaccine policy knowledge is really important, because in the 1990s, of course, at the same time as the universal birth dose, there was also a recommendation, a risk-based recommendation for adolescents to be vaccinated against hepatitis B that also indicated and sort of showed us through experience that targeted recommendations did not work. So adolescent universal recommendations were promulgated in 1995 with catch-up for anyone up to age 18 in 1997. So I just want to make sure people understand that historically it's really important to understand the vaccination policy as we look through these data. Again, historically, I think that's why we've seen that ACIP from the time that you all have, the committee had sort of pointed out that the original recommendation did not go through GRADE or ETR. It wasn't being done at the time. So I think that because we have evolved and learned over the last 20 years that this type of rigorous exploration of all of the data it is critically important before making a policy decision that affects millions of people. There's been a lot of data and some misinformation presented today and it becomes overwhelming and disorganized. It would be really helpful to see a comprehensive, organized presentation pertaining to these votes that really explore the risks and benefits of vaccination and any vaccination policy, any actual public health problem with the current practice that's being addressed, feasibility of the change, values, acceptability, resources. These decisions really affect a lot of people's lives, and we really are obligated to our countrymen to make sure that we do this in an organized process. We can't just dump a pile of unfolded laundry on the floor and then try to determine from that whether or not we need more t-shirts or more pants. We can't look at the pros and cons, the risks and benefits.
Amy, I appreciate this, but we are under tight timelines.
Can I respond to that?
Yes, you can.
Is there an urgency with the vote? I didn't understand. Is there an urgency that we're addressing with the urgency of that fee?
The urgency is that we have a number of other colleagues of yours that would also like to comment.
Great.
Retzef.
I'm done. Thanks so much.
Yeah,
thank you so much.
So thanks for the last comment. I actually think it's a great comment. I just want to build on that. So first, let me just clarify. The slide you pointed to is CDC data. It's not misinformation, just to make sure that everybody understands what data we're looking at. And this is a data that is used to make the assertion that the universal dose of Hep B that was instituted first in 1991 and was fully enforced in 2005 is responsible for the major decrease that we see in the overall number of acute cases in the U.S. This statement is factually not correct. And the way to see that is not correct is to notice which one of the colors are going down. And the colors that are going down are of ages that at the time, at the years that we are looking at, the babies that were vaccinated after 1991 were not on those age groups. These are older people. Now, you mentioned correctly that there were other interventions that were applied to the high-risk populations. And you're just reinforcing the sentiment of this of the proposed vote, which is to focus on the high-risk population, because that's what drives the reduction in cases. So we are in violent agreement, other than the fact that...
I'm sorry. I have to interrupt. We're not in agreement. The risk-based strategy to address adolescence was not successful, and that is why there was a universal recommendation in 1995. I'm only referring to the fact that you cannot use the fact that the rates went down in later teens and younger 20s as any example that the universal immunization recommendation for the birth dose was ineffective. That's my point.
I appreciate...
There were multiple issues, and they were all successful.
Yeah, I may say that I appreciate your beliefs and feelings about this, but these beliefs and feelings are not supported by the data that was presented in front of us by the CDC. Anybody that would look on the graph that was provided by the CDC has to conclude that the reduction in cases is coming from age groups that were not relevant to the universal dose at the time when the decrease is observed. And that the only conclusion is that there are other interventions that I think were well targeted at the high-risk populations that caused that reduction. And very good that these policies were implemented. The inpatient that people had at the time in 1991, 5 years after they started these high-risk focus policies, and I think I also heard from some of your colleagues that we need to be patient with public health policies. I think we just showed impatience, and we rushed to essentially vaccinate every single baby in this country, something that other countries considered, and concluded based on similar data that is highly not cost effective and potentially also carries serious risk of harm. So I appreciate beliefs and feelings, but the data presented to us by the CDC, not misinformation, is telling a different story than what you believe in.
This is not beliefs and feelings. This is looking at the data, and I will also. I'm sorry, my phone keeps going off.
Can we agree to disagree on that and move on to?
Well, my main point is that if we could see all of these data organized in a reasonable fashion, in an evidence to recommendation fashion, where we could look at all of the data rather than cherry pick one or two studies, it's critically important for us to make a decision of this import to have all of the data laid out in front of us in an organized way that assesses all of the risks and benefits based on evidence and not anecdotes.
Thank you, Dr. Middleman.
I have a critical question here, and that is Dr. Middleman said that risk-based administration did not work for adolescents, and that is a critical question before this committee for these considerations, because we're talking about moving to risk-based evidence. So please clarify for us what you mean by saying risk-based administration did not work. Please elaborate for us and help us understand that.
Are you talking to me?
Yes, please.
Amy, well, so it's been a long time. I don't have all of the specific studies at hand, but what I can tell you is that the recommendation was made in the early 1990s to try and immunize adolescents who were at risk, which meant that they were either in underserved areas or that they were engaging in high-risk behaviors. That failed to increase immunization rates because, for equity reasons, obviously those are the exact people who have less access to the provider, less access to doctors, and are not going to go specifically and answer those questions. So when the recommendation was changed, it was changed to a universal recommendation so that we could eliminate disparities and inequities and vaccinate everyone so that everyone remains safe. When we vaccinate the most vulnerable in our population, we have a much greater chance of eliminating the transmission of disease by this most vulnerable population. This has been shown in other, I defer to the CDC subject matter experts. Perhaps they'd like to join in on some of the additional data that's available that shows that risk-based recommendations do not usually work.
Appreciate that, Dr. Middleman. Appreciate the discussion, both of you. But right now, we're in a session where we're focusing on the liaisons, and we don't have a whole lot of time left. So in the interest of allowing your other liaison members to share their opinions, I ask that we please curtail this discussion now, which in my opinion seems to be going around and around and ending up that there's a broad disagreement on the interpretation of key data. So with that, we're now at Sandra Freihofer. Dr. Freihofer?
Thank you, Dr. Malone. I'm Sandra Freihofer, AMA liaison, and I'm speaking on behalf of the American Medical Association. A dose of hepatitis B vaccine at birth is crucial for protecting infants from perinatal and early postnatal transmission. Maternal infant transmission of hepatitis B virus results in chronic infection for 90% of infected infants, which can lead to liver disease, cirrhosis, liver cancer, and death. The birth dose of hepatitis B vaccine helps ensure universal protection for all newborns, even those with incomplete prenatal records, or even for those whose mothers may have missed maternal screening. The birth dose of hepatitis B vaccine has prevented more than 6 million hepatitis B virus infections and nearly 1 million hospitalizations for HPV-related diseases. The American Medical Association strongly urges ACIP to maintain its recommendations for a birth dose of hepatitis B vaccine. And on a personal note, I'm a mother and a grandmother. My boy-girl twins both had little babies right before Thanksgiving. Both moms were vaccinated against COVID, flu, and RSV during their pregnancy, and both of my new little grandsons got a birth dose of hepatitis B vaccine. So what I'm telling you is what I believe for my family. Thank you, Dr. Malone.
Thank you, Dr. Freihofer. Can you elaborate on the origin of the infections saved data that you're referring to? Are those data or are those the results of modeling studies?
Those are data that are from the American Medical Association, and I think we need to move on to our next liaison to give other people time to speak up.
I see. The next is Carol Hayes.
Yes, this is Carol Hayes with the American College of Nurse Midwives. I would just like to say that we, ACNM, completely supports what Dr. Freihofer just said, and the birth dose of hepatitis B is critically important for the newborns of this country. I also want to say that I've been a nurse midwife for almost 39 years, and I remember before these vaccines were around. I conducted a study in 1987 on pregnant women's assessment of their own risk for getting HIV, and you can probably guess what my data showed. We also have found that the resurgence of congenital syphilis is a good example of why risk-based approach is flawed. It is not in the best interest of most pregnant women and their newborns. I also want to say that I have seen clinicians and office staff in the clinic not differentiate between antibodies and antigens. And I know that to this group, that probably seems incredibly infantile, but I have seen it many times. Thank you for the opportunity to make a comment.
Roger that. Thank you. Ashley Halbritter.
Can I make one sentence comment?
Okay, fire away.
Sorry. I think one of the important points to remember is that hepatitis B is from a chronically infected mother is transmitted almost entirely at the time of birth. That is, only 1 or 2% of the cases are acquired in utero. It's during the birth process. So administration of intervention very soon after birth is really very, very critical.
And just to recap, I think there's broad consensus that that's the case. I don't think that's something that's a subject of disagreement on, that the HBs antigen positive mother there is a recommendation on administration of both immunoglobulin and vaccination at the time of delivery. I think that's a broad consensus that is not, I'm not aware of that being a subject of discussion.
But my point, the reason I say it is because there is a brief window of opportunity to prevent transmission from the mother to her baby.
But this is not a area of any disagreement. There's no disagreement on that point.
But the baby is healthy, and if you treat it right away, you can make it. It's unlike CMV.
Once again, Cody, there is no disagreement on this point.
Okay, okay.
Fair enough. So Ashley Halbritter. Ashley, are you there? Okay, I apologize, Ashley, that we have outlived your patience. Barbara Resnick. Barbara, are you there?
Yes, no additional comments at this time.
Oh, bless your heart. Carolyn Ha. I'm hearing Carolyn a little bit. Is that right? Carolyn, are you there? I guess not. Christine Hahn.
Yeah, hi. I'm a liaison from CSTE, but I did not raise my hand to speak.
Okay. I apologize. Judith.
It's okay.
Judith Schley.
Yeah, hi. I have a couple more comments that I wanted to make. I'm from NACHO, representing as a liaison to NACHO. One of the things that Dr. Nevison talked about older people having higher rates of hepatitis B in the data she was showing. And think of that as those are people now that maybe their grandparents that are coming over and that risk of horizontal transmission for a baby that did not get the hepatitis B birth dose. The second thing I wanted to bring up is I'm also a practicing physician, and we always, and I run immunization programs, we always do informed consent, even on vaccines that are recommended by the CDC, irrespective, as Dr. Morris spoke earlier. And the last thing I wanted to bring up was the health outcomes of the United States compared to other developed nations. We spend the most on healthcare costs, and our outcomes are the worst compared to other developed nations. So here we have a program that works quite well. Vaccines are very cost effective, and we can reduce any harm and protect the entire population. Thank you for your time.
Dr. Schley, I applaud your commitment to informed consent. It's something that we share. Did I understand you in your first comment that your interpretation of the paradoxical increase in hepatitis B infection and disease in the elderly is being driven by an immigrant population? Did I understand that correctly?
I didn't say that. I just said from the note, what Dr. Nevison said was it's going up in the older populations. And I just, then those people are at risk for transmission to others, including newborn babies, because, you know, grandparents come over and see the kids, right? And
oh, that's what you meant by,
I
misunderstood. When you said come over, I was inferring that you were referring to immigrants, and in fact, you were referring to grandparents visiting their kids, something that's near and dear to my heart.
Well, that's a good, and it's sort of like the Tdap cocooning that we work on to cocoon the baby. So our mothers who are pregnant get vaccinated with Tdap, but we want to also have the whole family who's going to see that baby get vaccinated so we don't give that child whooping cough before they can be protected. This is the same type of thing that if we're seeing it higher in older people, then they could transmit unknowingly to their
I appreciate the clarification and suggests that this issue of cocooning and vaccine recommendations for adults and elderly having to do with risk of transmission to neonates is a topic that ACIP should consider at some point, because it seems like there needs to be a recommendation there, in my opinion. Phyllis Arthur, you represent a fairly large constituency. What do you have to share with us?
Hi, Dr. Malone. Thank you so much for calling on me. Actually, unrelated to the discussion that's happening now, I was actually raising my hand to comment on your very nice discussion of the working groups that are going to be formed and the TORs that we should be expecting. And so I actually wanted to make a request and make sure this fits the FACA guidelines as have been discussed. In the past, as you said, the content of the discussions was not talked about at committee except for to drive recommendations. But the working group members on those working groups were posted on the CDC website. We saw the slide that you showed earlier. I would like to request that as the TORs are finalized for all working groups, that the names of the working group members, again, be posted on the website, just so we understand who is part of those closed door discussions. We'd also like to ask that the working groups potentially go back to having industry present in those closed work groups, so that you can ask some questions of each individual company that may be proprietary in nature. So those are just two requests with regard to process moving forward. Thank you.
Duly noted. And I have been educated today by our CDC liaison that the FAR does allow for discretion about disclosure of working group members. So we're going to have to put a process in place, I infer, in which we get authorization from working group members to have their names disclosed. But I very much appreciate your comments, Ms. Arthur. Now, we have Mike Ibarra up next. Mike, are you there?
Yes, thanks, Dr. Malone. Thanks for the opportunity to participate and for calling on me. My name is Michael Ibarra. I'm the Chief Medical Officer at Pharma, and I'm also an emergency physician. I practice clinically at a liver transplant center. So I just want to align with the comments made by the other liaison reps that were physicians that made comments about how the public may not realize how significant advanced liver disease and patients that come to the emergency department with complications often are among the sickest that we care for in the emergency department in the hospital. So this is a very serious conversation. I echo the comments made by my other liaison reps, including Ms. Arthur from Bio. We submitted formal comments to the docket that I just want to build on the point that Phyllis made in terms of appreciate sharing the committee's decision to update us on the composition of the work groups. We just encourage exploring ways to broaden the expertise and stakeholder participation in future work group conversations. So thanks for the opportunity to participate.
Thank you for your kind and well-reasoned use of language regarding this. I personally think that we're much better served if we approach these challenging issues as colleagues rather than in confrontation, which sometimes seems to be the case. I think unnecessary, in my opinion. I'm just editorializing. With that now, who are we missing? Sandra Freihofer, are you, have you been heard or is there additional information that you wish to share? Okay, then with that, our colleague, Dr.
Malone.
Yes, I'm just getting there, Jason. Patience is a virtue. Jason Goldman, please. I look forward to your additional comments.
Thank you, sir. Well, first, let me applaud you for your graciousness in allowing us to speak at the end of the meeting, given the time constraints. Not only am I president of the American College of Physicians, representing over 160,000 internal medicine specialists throughout the world, I am also a primary care physician in general internal medicine practice in my own office who vaccinates patients and deals with informed consent for every single thing we do that is part and parcel of primary care and internal medicine. So I have a few questions that I'd appreciate if the committee would consider in the upcoming vote. Given that your first vote speaks to the problem of a process based on anecdotes of patients not having informed consent, how does changing the recommendations and going against decades of data and safety and efficacy correct the problem of process of not having informed consent? That's question one. Number two, what analysis do you have on the projected outcomes that a change to the recommendations will have in terms of disease burden, financial cost, access to health care, health equity, recurrence of disease? Number three, the committee has made comments about the change being necessary because several stakeholders actually want this vote changed. Who are those stakeholders? How were they surveyed? Where is the data that shows they want it changed? What is the conflicts of interests? Also, number four, where are the liaisons on the work groups? Why have they been removed? So in other words, for the majority of these questions, they can be answered by the evidence to recommend framework, which looks at all of these issues as to why we should have a change and how we have that intervention and what are the downstream effects of everything we do. As has been echoed, primum non nocere, first do no harm. We need to make sure that we are acting in the best interest of our patients. So I appreciate the work to look at this, but can we please go back to a good, solid solid evidence to recommend framework where we answer all these questions and look at the potential outcomes so that we don't unnecessarily harm patients, given that the hepatitis B birth dose has been such a great success in reducing liver disease throughout the country. Thank you for your time.
Thank you, Jason.
Robert,
if I may take the privilege of the chair to answer the few of those questions that I think I have information on. Regarding the liaisons participating in work groups, I may be wrong in this, but my understanding is that the charter coming to us from the Federal Advisory Committee Act, Congressional Act, indicates that work group members may represent themselves, but they shall not represent, for instance, a interest group such as a physicians organization. So my understanding that was, and I'm glad that we have an opportunity to talk about this, because it's been widely the actions of the Secretary have been widely misrepresented in various outlets. My understanding is that a lot of this was driven by FACA rules, and that individuals with expertise relevant to the topic of the working group that represent themselves it is allowed, this is my understanding of the FACA guidance, and we have had training in this, but that individuals representing the interests of some group, including an industry group, such as the various physicians organizations, is not consistent with the FACA guidelines. Do I understand that correctly? Yes, I get confirmation that, in fact, I'm not being stupid, and I did remember my training on the FACA rules. Let's see now. Retzif, I think you have some comments.
Yeah, so first, I think if you listened carefully to the presentation, there was actually clear discussion of surveys of patients that were unsatisfied with the current policy. We also talked with the fact that some people cannot send their children to daycare or cannot get clinical care. So maybe this is not the stakeholders that you are prioritizing, and I respect that. That's fair. That's why we have a discussion. But I don't think it's honest to say that these were not discussed. And the other thing that I would like to say is
drill down, sir.
Let me please finish. You usually speak quite a lot for a long time, and please let me finish because it takes time also to address back your questions. You ask a few questions. I want to answer them. So we are using the ETR and the grade as some magic words. But I just want to share two observations about the ETR and the grade. The first of which is that the ETR and the grade were used to support, approve, push, and recommend these vaccines to highly low-risk, healthy children against SARS-CoV-2. Something that I think is one of the most outrageous decisions historically. So I'm not sure I buy the concept that ETR and grade guarantees cannot be abused to actually justify using very low quality data to justify whatever recommendation you want. We don't have ETR like we assume in advance what we are going to recommend. I think that this work group, like the other work groups, considered many opinions, had a diverse set of perspectives, considered all the data that was provided by the CDC, went well beyond that, and did work that I don't think has been done in any of the recent votes that we've seen in the prior ACIP groups, and definitely not the decisions of ACIP that instituted many of the policies that we currently discuss. So with all due respect, it will be much better to argue about what facts and what assumptions you disagree with than to keep coming back and suggest that the people in front of you are not doing serious work. I reject that. With all due respect, I reject that assertion.
You need to be honest and truthful.
We are honest and truthful just as you are, sir.
We're talking about hepatitis B, not COVID. We're talking about a framework that is applied to all decisions.
But
why are you bringing
if
up
I may,
COVID?
if I may interject, Dr. Goldman, we have all the members here. You are not privileged to the fact that we have had specific training in grade from specialists, and one of the observations is that that system is very dependent on the integrity of the data available to and the breadth of the data available to address the question. And I'm sure you're very familiar with that because you're very experienced, and you know that to be frank, it's a problem well known in the information technology space that if we have low quality data, we get low quality decisions. There's a acronym GIGO that is less pleasant in making that point. I wish to, I've been updated regarding the liaison removal question. And I want to share this because we're on the public record and we have various colleagues here from the press. In 2010, the CDC began implementing the removal of all liaisons from FACA committees within the CDC. So this was not a new initiative with the last election. This has been ongoing since 2010. ACIP was one of the few that didn't remove liaison members from the working groups. So that was in contrast to the vast majority of the FACA committees that exist within the CDC, of which this is just one. In June 2025, there was a decision to correct that and to ensure that the ACIP was in alignment with the policies and procedures of the Federal Advisory Committee Act. And I can attest that we have had specific training and commentary from the CDC's FACA expert that has guided these changes and our implementation. So this is not, it's not random, it's not arbitrary, it's not capricious. It's a part of an attempt by the CDC begun in 2010 to bring all of the CDC advisory committees, of which ACIP is only one, in compliance that were previously not in compliance with the Federal Advisory Committee Act, the FACA. And so, again, there's no discrimination here against the various, I'm trying to choose my words, the various medical practitioner specialty organizations and boarding organizations, but rather a systematic attempt to methodically bring Advisory Committee on Immunization Practices in alignment with both CDC policy and congressional FACA policy, which is what impanels the ACIP and the other FACA committees. So with that diatribe, forgive me, but I appreciate the opportunity to share that information. We will adjourn for today.
That was excellent. I need to jump in on the evidence to recommendations question. For many weeks now, I have been advocating in our committee that we have a scientific framework for making our decisions. Because if we don't have a scientific framework, they are susceptible to
and we have heard your comments,
so,
and please understand that there is a process in place.
Please do not interrupt me. Please do not interrupt me. Yes, it is the critical issue for us has been, should there be a scientific framework or should there be no scientific framework? As we discussed a scientific framework, I opened the question as to whether or not there is a better scientific framework than GRADE or ETR. no valid scientific frameworks were proposed. We have subsequently been trained in both the GRADE and ETR processes, and I hope that we should use them to formulate our questions so that we don't have any more grand confusions about what our questions, what the critical questions are that we're doing. So we are moving towards using the ETR process. The training came a little bit late for this meeting, but we hope to be using that. Retzif is right. Anything can be abused. Anything can be distorted. But it is better than having no scientific framework whatsoever.
Thank you for sharing your perspective. With that, we're adjourned for the day, and we convene tomorrow at what time, Mina? 8:30. So for those interested, I look forward to seeing you tomorrow at 8:30 in the morning, and thank all of you for your intestinal fortitude, patience, and commitment. With that, we're adjourned.